Good morning, everyone, and welcome to the 11th Annual Spring Retina Update. On behalf of all of my colleagues here at the Retina Institute, I wish to welcome you. This meeting is made possible in part by a grant supplied by the Retina Research and Development Foundation. My colleagues are listed here along with their disclosures, and this will be playing again during the video break time. I want to especially recognize my fellow members of the Conference Planning Committee, Drs. Blackerby and Dr. Frummel, who have been instrumental in putting this agenda together for you this morning. I also want to recognize Nancy Belosky, who without her, we could not have this meeting. Now, she's responsible for doing the applications for 3 different continuing education accreditation entities so that each of you attending today can receive continuing education credits. We've gone through great lengths to make sure there's no bias in this meeting. There's no sponsors from any industry. And speaking of continuing education credits, make sure that you fill out the survey that you will receive in your email inboxes. That is due by May 5th. Some of you, particularly technicians who are seeking JCAPO credits, will need to do a quiz, and a passing score of 80% is required for that. So with that, I want to turn it over to our first speaker, Dr. Thanos Papakostas, who will be talking to us about retinal detachment repair with vitrectomy.
Okay, good morning to everybody. Thanks for being here today. It's always tough to do meetings on a Saturday, but we very much appreciate the fact that you're logging in and participating in the meeting. So today I'm going to be talking about vitrectomy for retinal detachment repair. Retinal detachments are the most common emergencies that we deal with. Many of you are referring your patients to us, and we're thankful for your partnership. And I'm going to walk you through how we do the surgery and, what goes into our thinking, how we fix these cases, which procedure we pick, and why we do vitrectomies for retinal detachment repair, not other procedures. So these are my financial disclosures. None is relevant to this talk. So what are the goals of this talk? The goals are 2. I'm going to walk you over the principles of vitrectomy for retinal detachment, and then I'm going to present data from a critical standpoint. Which technique is the best? Vitrectomy, sclerobuckle, or both? So let's start with the principles of vitrectomy for retinal detachment repair. There are 4 key principles that we follow when we fix these eyes with retinal detachment. The first is visualization. If you cannot see, you cannot operate. Visualization is probably one of the most important things in surgery. Second is find the breaks. Third is relieve the traction. And fourth is seal the tears. And let's start with visualization. The first major milestone in our field was in the late 80s, early 90s. We had panoramic viewing systems, the Avi lens that was developed in New York by Professor Chang and Avi Greenblatt. So that was revolutionary for retinal detachment repairs because before the viewing systems would give you a very narrow view. So it would be really hard to see the whole retina while you're doing the surgery. Now, for the first time, you can actually see the whole thing, which is key in the surgical approach. And then as things evolved, we went from contact systems to non-contact systems. And these are the most commonly used non-contact systems nowadays. It's the Biome and the Resite. They give you slightly narrower view than the Avi lens. It's about 10 to 20 degrees less field of view. But the major advantage is that you do not depend on the assistant. And that's key because we're fortunate to operate with fellows. We assist them, they assist us. But many surgeons around the country, they operate on their own. So these systems are key so that you can do the surgery efficiently. And then, of course, you can couple non-contact systems with heads-up displays like the Angiography or other systems marketed by other companies. and you can even use digital VR headsets. So what's the main principle of visualization with the non-contact systems? The idea is that the further you are from the eye, the further the lens is from the eye, the more narrow the field of view is. The closer you are to the eye, the wider the field of view you have. So the distance between the lens and the corneal apex will determine the field of view, and I'm going to give you an example. This is the field of view you get when the lens is far away from the cornea. And then when you go closer to the eye, this is the field of view. It's like looking through a keyhole, basically. The further you are from the keyhole, the narrower the field of view is. And then when you go close to the keyhole, the field of view expands. And when we do the surgery, it's not a static process, but it's a dynamic process. We usually tend to move the eye in certain directions. And when the eye moves, the lens has to move. And as you can see here, the distance has increased. So the lens has to go closer to the eye in order to get a wider view. So essentially what we're doing all the time with these systems and the lenses, I call it the biome dance. You just move the eye and you move the scope all the time. So you get the necessary view in order to achieve all the surgical maneuvers by constantly readjusting and constantly moving the scope and the eye. Second is find the breaks. You can follow the Linkoff rules to find the breaks. Dr. Linkoff was a key figure in the retina field that practiced in New York for many, many years in the 70s, 80s, and 90s. And in the late 70s, he developed these rules that basically apply for almost all the retinal detachments we can encounter in the clinic. So if you follow his rules, you will be able to find the break. Then, of course, during the surgery, we like to depress on the sclera so we can indent the eye and identify in a dynamic fashion all the breaks in the retina. As you can see here, the assistant is depressing, the surgeon is shaving the vitreous base, and then we can identify all the breaks. Depression is key because you can actually open up a break. You can actually see the flap in a very nice way. Otherwise, it's really hard to identify very small breaks. I mean, obviously, big breaks, you can see them, but small breaks, I think depression is key because you're going to be opening up the flap of the break and you're going to be able to identify and relieve the traction. Of course, relieve the traction, as we said before, this retinal detachment had one break supratemporally, and as you can see here, the assistant is depressing, and then we do a meticulous vitreous base shaving there to relieve the traction. When things are really bullous and the retina is extremely mobile, you can use a heavy liquid to stabilize the retina, and this way you can relieve the traction without the retina coming into your way. So as the field has evolved, we started back in the day with 20 gauge cutters, and now we're using 25 or 27 gauge cutters. The beauty with the small gauge cutters is that you have a smaller sphere of influence. A sphere of influence is essentially the area that all the action is going to be happening around the cutter. So the smaller the sphere of influence is, the less iatrogenic damage you're going to do to the retina, the less traction you're going to achieve on unwanted areas. So with the 20 gauge cutters in the past, as you can imagine, the sphere of influence was fairly large. So by going closer to the retina, there was a risk that you could actually damage the retina. But now with these smaller cutters, you can actually go very close to the retina and do a meticulous shave without causing any iatrogenic tears. And of course, seal the breaks after you flatten the retina. And we like to flatten the retina, drain the subretinal fluid, either through the break using a drainage retinotomy or with a heavy liquid like perfluorocarbon. and then apply laser. So I'm going to show you different ways of draining. This is a drainage through the break. So what we do is we take a soft tip and we aspirate the subretinal fluid while the infusion is pushing air in the eye. And then when the retina is flat, we apply laser around the break. Or you can do a drainage retinotomy. That's another very nice technique to achieve drainage of subretinal fluid. Here we're under air. We tried to drain through the break, but there was a significant amount of fluid left. You can see this blister of fluid in the mid-periphery. We make a diathermy. We use a diathermy spot to mark our drainage retinotomy, and then with the soft tip, we'll go over the white spot, the diathermy spot. We aspirate. This retinotomy opens up, and then we evacuate all the subretinal fluid. And then after we finish the surgery with laser and drainage of the subretinal fluid, we have to use some sort of tamponade to fix the retina. The tamponade is, I like to call it like a cast, right? When you break, a bone, when you break your arm, the orthopedic surgeon put the cast around the arm when they reduce the fracture. It's the same thing. You have to put something to keep the retina in place while the laser creates a scar around the tear. The laser usually takes about 10 days to create the scar. So you need some sort of tamponade agent that works for a minimum of 10 days. So we like to use SF6, which works for about 2 to 3 weeks, or C3F8, which is the long-acting gas that works for about 6 to 8 weeks. SF6 would be a great option if you have perhaps 1 or 2 superior breaks. And C3F8 would be a very good option if you have multiple breaks and many of them located in the inferior quadrants. Silicone oil gives you a permanent tamponade. Silicone oil is not going to be absorbed by the eye. You have to remove it with a second surgery, and that's used in complicated retinal detachments or when patients have to fly. So now I'm going to go to the second part of my talk, and I'm going to try to address this perennial question that everybody has. When you see retinal detachment, how do you fix it? Do you do vitrectomy? Do you do a scleral buckle, or you just do both of them? So I'm going to start with a case. This is a 65-year-old man, pseudophakic, with a hilodal separation with a PVD. There's a single superior large break with lattice and a bridging vessel. I think most of us would agree that the vitrectomy is the best choice in this eye. And then case number 2, here's a 25-year-old man, no PVD, and there's a retinal dialysis after trauma. You can see the large dialysis infratemporally. I think the majority of the surgeons would do a scleral buckle, and these are 2 clear-cut cases, right, where there's not going to be any dichotomy in opinions. Most of the surgeons, I would say more than 95% of the surgeons would agree on these options. But what about the rest? Which technique is the best? So the first study that tried to answer this question was the SPR trial. It was done in Europe, 45 surgeons from 25 centers, that they randomized 681 eyes on scleral buckle versus vitrectomy. However, when you go to the details of the study, the surgeons were allowed to add a buckle in the vitrectomy group per discretion. So in essence, you're looking at the scleral buckle versus scleral buckle with, if you allow me the expression, glorified pneumatic with a vitrectomy, because 70% of the eyes received a combined procedure. So the randomization didn't really work as the investigators expected. And when you look at the results in phakic eyes, the success rate is about 74%. And when you look at pseudophakic eyes, the scleral buckle alone group was 60%, while the vitrectomy group was about 80%. Really, these success rates are much lower than what we do nowadays, and perhaps if someone showed the success rates in a meeting today that these are the results you get with vitrectomy, people will be scratching their heads. When you look at real-world data, these are real-world data from 9,000 Medicare beneficiaries. There is about 20% failure for both procedures, about 20% for scleral buckle and about 20% for pars plana vitrectomy. So the caveat with the SPR trial was that the vitrectomy techniques were not the techniques we're using nowadays. The instrumentation was nothing compared to what we use nowadays. So someone can make the argument, how can you draw conclusions from techniques that are largely abandoned or instrumentation that is not used anymore? So that begs the question, what are the results with modern vitreoretinal techniques, especially for vitrectomy? So the PRO study was a study that was done back in 2015. 5 centers contributed cases to this study. The Retina Institute was one of the 5 centers. The other 4 were Masqueraders, Wheels, ARC Beaumont, and VRS group in Minneapolis. So basically high volume groups around the country that deal with a very large volume of retinal detachments. 61 surgeons were included in the study, about 2,300 eyes, and the patients received buckles, vitrectomies, or both. The eyes that were included, they had to have primary retinal detachments that were non-complicated. That means no proliferative vitreous retinopathy, no giant tears, no trauma. Essentially, if you allow me the expression, a garden variety retinal detachment, not something overly complicated. When you look at the phakic group, buckle wins, as you can see here with the success rates, 91%, almost 92% versus 83. And when you look at the pseudophakic group, the adjuvant buckle wins, 92% versus 84%. So in essence, the take-home message from the PRO study is always place a scleral buckle. However, there's a disconnect with smaller studies. There was a study from Masqueraders, 187 eyes, 4 surgeons, where they reported a very high success rate with vitrectomy. And then another study from University of Michigan, 1 surgeon, 93 consecutive eyes with a similarly high success rate. But when you take a deep dive into the PRO data and you stratify the PRO data by surgeon, when you look at the raw failure data for the vitrectomy group, and you put the bar at about 40% failure, you have some surgeons that operated the higher failure than that. So 6 out of the 61 surgeons had a vitrectomy failure rate greater than 40%, and 43 out of 84 eyes was about 51% failure rate. There was no difference in the patient age and inferior RD rate in this cohort. So after you exclude the underperformers, then all the differences that the PRO study was advocating before, they mostly go away because the percentages of success are very similar between buccal vitrectomy and scleral buckle with vitrectomy. And in the pseudophakic group, you get similar results. A meta-analysis was performed comparing scleral buckle versus vitrectomy, and the conclusion was buckle was not superior to vitrectomy. There's low certainty evidence from randomized clinical trials that demonstrate a benefit of placing supplemental buckle during vitrectomy. So when I show this data, some might say, well, you can't really cherry pick, right? Because you're excluding underperformers. This is exactly what cherry picking is. You just like exclude people that don't match your hypothesis. However, is it really cherry picking from a strict statistics standpoint? Values that are off a certain range of quartile range can be excluded. These are the so-called outliers. And from a practical standpoint, in surgery outcomes, surgeon factor is a key. So really, someone that operates at a 50% success rate, the surgery is probably very different than the surgeon that operates at an 80% or 85 or 90% success rate. So when you look at the low performers versus pneumatic retinopaxies, it's extremely similar. So the 50% failure rate is comparable to the 40% failure rate of pneumatic retinopexy. And the 40% failure rate comes from real world data. It doesn't come from the Canadian studies. It comes from real world data from Medicare beneficiaries. So in summary, the success rate with vitrectomy is higher than the old SPR era. I remind you the study was done in the late 90s, early 2000s. There was no difference between sclerobuckle and vitrectomy, and the role of adjuvant sclerobuckle remains controversial. Evidence of adding a buckle still remains weak in my opinion. And I think as a field we have to focus more on the failures and not the successes. I don't think there is a need to run another massive trial to figure out which technique is the best. I think we have to dissect the failures, why people are failing, why you get 50% failure with some surgeons on vitrectomy. But overall, there is the data are getting better as the years pass because of instrumentation. And of course, surgeon factor is a key. Thank you very much for your attention.
Thanks, Thanos. That was a great talk as usual. Even as I've been doing this for a while now, I really appreciated the talk on the viewing systems. It's kind of something that we take for granted because we're just so used to it. But it's kind of nice to see the techniques again of moving the scopes around, especially all of us here who are like engaging with teaching fellows. Any questions from the panel?
Thanos, we've got some updates to vitrectomy platforms coming out in the near future. How much do you see this impacting or improving our success rate with the new generation of vitrectomy with higher cut rates and lower gauges, smaller gauges affecting us?
Yeah, I think what's going to happen is I like to call it the democratization of retinal detachment surgery. You're going to basically see success rates getting higher and aligning, across one bar for everybody. It's because it's the system now that will minimize damage to the retina. Up to this point, the surgeons had to take care not to damage the retina, but now with these newer systems, it's going to be extremely hard to inflict damage to the retina, to cause iatrogenic tears. So the new system that is coming from Alcon can operate at very high speeds with high flow without exerting any significant traction on the retina. And there are also platforms that will be integrated in the vitrectomy systems and the visualization systems, not in the near future, probably in the mid-near future, in the midterm future. AI algorithms that basically warn you when you're close to create a problem. And there are groups around the country that are working on that. So I would envision perhaps in 5 or 10 years from now to work with systems that will give you warnings, that will give you active feedback during the surgery that, hey, you might want to move away from this area because you're probably going to cause more trouble there, which we don't have a way right now to do it. It depends on how experienced the surgeon is, how many cases you have under your belt, basically.
Dennis, I'm sorry, I may have missed it, but in your pro analysis, when you look at the remaining surgeons who did not have the high failure rate, what was the rate of them placing a buckle on the eye? Just guesstimating.
So I don't have this answer to tell you. I don't know what the rate. I don't remember what the rate of placing a buckle, but I remember this when we looked at the underperformers, the people that were basically performing less than 60% success rate, and we looked at their buckle outcomes. Their buckle outcomes were actually great. They were about 91 to 93%. Of course, these surgeons are de-identified, so you really don't know who they are, what they did. But when you look at how they performed doing scleral buckles, the success rate was totally flipped.
Mhm. I think your talk really highlights the heterogeneity of this disease of retinal detachment. I mean, the same retinal detachment in one eye is not necessarily the same retinal detachment in the exact same scenario of a different patient. You know, every patient has different needs. They may be faced with travel across the ocean, that sort of thing. So maybe the panels you could respond to, like how do you take into account those various scenarios of each patient when you're choosing a vitrectomy versus a buccal or both or a pneumatic?
Yes, so for vitrectomy, I like to do vitrectomies when I see a high lodal separation. When there is a PVD, I think the vitrectomy is the best option for this patient. When there's no high lodal separation, I like to do scleral buckles, and the scleral buckle becomes actually a fairly easy surgery when the hyaloid is attached. It's not a very complicated surgery. When you look at scleral buckle as a surgery compared to any other surgery in the human body, for the right cases, it has a very high success rate. But for hilodal separation, which is the majority of the retinal detachments we see, I think vitrectomy is a better option.
Others? Anyone else want to comment?
What are your go-to elements when you put a buckle on? Are you a tire fan or just a straight band?
It's a straight band. It's a 42 band. It's a 42 band, and then if a brake is a little bit more posterior, or I want to give an extra kick to a brake, I will put a 106 element.
Mhm.
The 42 band is wide enough to capture most of the pathology that you need at the vitreous base.
Dr. Smith, I would contend that even the heterogeneity exists even within the same patients. And it can be a difficult conversation to have. They've had a vitrectomy years ago by a different surgeon, and it was repaired one way, and they had the expectation, if it was successful, that they want it the same way, or if it was unsuccessful, they wanted it a different way. But even within that same patient, the breaks may be at different places. There may be early scar tissue development. That can be a tough conversation to have with them, especially if things don't work well initially. That's the most difficult part, I think, about interpreting any of these data is, even in my short time doing this, every detachment is totally different from another detachment. So how do you actually compile all these data into one set to give you an answer? And maybe, as Thanos was alluding to, maybe there isn't a set answer here, and doing more large-scale studies is just going to muddle the waters more, you know?
Yeah, I agree with you. I think, you know, this is, as Thanos was saying, this is a hard topic to study. And in order, I mean, it'd be almost nearly impossible to do a randomized controlled trial because you'd have to have surgeons who believe that either or are the same surgery and are adept at performing anything in order to ethically allow randomization of a patient into one or the other. Each surgeon in a trial would have to believe that a vitrectomy is good, a buckle is good, a vitrectomy buckle is good.
Yeah, I absolutely agree. And I think this is the beautiful part of retina too, right? No two detachments are the same, no two eyes are the same. And that's every time you have a case, no matter how many cases you've had, it's a different ball game. And that's what makes it so exciting and always new, that you can't just be on autopilot for any of the detachments cases. And that's what makes teaching very, very rewarding as well. And yes, I think the data that we have right now can use just as general guides, but I think the art of medicine comes in by interpreting those subtle differences. And that's why I think as we will be maybe a little bit more protected from the AI invasion into our field, because to make the determination, I think it will still take the human component in deciding what exactly to do in that particular situation.
Yeah. Just while we're waiting for a moment, just to remind our attendees, feel free to ask a question through the chat function at the bottom of your screen.
That's very good. Final comment. Excuse me, Thanos. Thank you for a great talk. I do think it's an important topic as we talk to the fellows now, and looking back over the 25 years of doing this, that the rate of retinal detachment continues to increase. There's more myopia. There's more 50-year-old pseudofakes than we've ever seen. When I started, I can't remember operating on hardly any 50-something-year-old detachments, and now it's at least, it seems like this all the time. So it's a sustainable problem. I don't know how we fix it otherwise, but something that's not going away and probably going to continue to grow for us as we look forward as one of our primary surgical procedures.
Yeah. Okay, well, we're a little ahead of schedule, but I think we'll just go ahead and move on to the next session, which we're going to highlight some surgery. Okay. Yeah, so this is a new session we're going to try to introduce this year for Spring Retina Update, just to kind of highlight surgery and talk more about surgery. So that's one of the more entertaining subjects that people like to look at, especially if you may not be in the operating room a lot. So this first case is one that Dr. Honosage actually did this case and was gracious enough to submit this for us to take a look at. I'm going to kind of drive while he kind of talks through this. Dr. Honosage, if you don't mind.
Sure, thank you. I really need to give a lot of the credit to Palak Patel, who's one of our fellows. Saw this patient on call, got them to the operating room, and did a great job with this patient. Unfortunately, she's working way harder than I am today right now, so I'm going to talk about it. This patient had known macular degeneration with vision loss, sudden vision loss on Valentine's Day last year. If you want to go to the next slide, Dr. Smith.
Sure.
Had good vision in his right eye. You can see numerous drusen. The left eye has numerous drusen, and unfortunately this large submacular hemorrhage. Now, I mentioned there's been 2 weeks of vision loss at this point, 2.5 weeks. There are options here. You could just watch it and just give up on the eye. That's one option, unfortunately, but in some cases, the best option. In his case, the options that were given to him were anti-VEGF injections, very reasonable. This is a large hemorrhage that has been there for a while. We usually think that phototoxicity develops after the first week or so with blood in the eye. So is there really much visual potential if we try and surgically evacuate this? But at the end of the day, he wanted to do surgery to see if we could get any sort of visual improvement centrally. And that's with a vitrectomy with a gas displacement and a tissue plasminogen activator dissolving of the clot. So if you'd like to go to the next slide. This is the surgical video starting with a core vitrectomy, using some Kenalog to highlight any residual vitreous. And then we use a contact lens here and use a very rigid small gauge cannula to inject tissue plasminogen activator, the same thing that they use as a clot buster for ischemic strokes, directly under the retina. And you essentially poke a hole into this clot, and then you can see a little air coming out. That can actually be quite nice to mix up the clot and the dissolving agent together. And then you start infusing in this TPA, and you form a bleb around this hemorrhage. And then you replace the vitreous with usually some sort of gas tamponade. The level of that tamponade varies person to person. We ended up using a full gas bubble here. The goal is to try and steamroll this dissolved clot away from the central retina and then allow the body to reabsorb it eventually. He did have a couple of incidental tears that were noted, which we lasered as well. And then after these surgeries, we usually encourage them to stay more upright to allow gravity to allow the dissolved clot to clear from the central retina. And I I mentioned he had a hand motion 2-week hemorrhage. So the prognosis in these kind of cases is quite guarded. And he knew even with clearance, there may be enough photoreceptor damage that he wouldn't see well. But somehow that was not the case here. We got really lucky. If you'd like to go to the next slide. And he ended up seeing great. He's seeing, to this day, I'm still seeing him, and he's seeing, depending on the day, 20/20, 20/25, pretty good photoreceptor integrity. I didn't believe it the first time the bubble had cleared halfway that he wasn't peaking, but indeed he really does see well in this eye. I am still giving him maintenance anti-VEGF injections. He's basically bought them for life. I'm giving him quarterly maintenance because he had such a blowout hemorrhage, and we're obviously watching the other eye really closely. But this case showed me that it's reasonable to not give up on these eyes, essentially. And it's also, if you have a patient that comes into your office and has had the hemorrhage for a couple of weeks, still send them to us, and we can talk to them about the options. And it's not the right option for everyone to go to the operating room. But in the cases that we do elect to go to the operating room, sometimes you can hit a home run, and that happens to be this case here. And if you want to go to the next slide, there's an article. Actually, there have been many articles about what do you do with these submacular hemorrhages. The harder a disease is to treat and the more visually devastating, the more people throw everything they can at it and see what sticks. So people have tried putting TPA intravitreally, and that seems to have some success. Anti-VEGF seems to have some success. Displacement seems to have some success, but there's no single answer for these. It also depends. Often these patients are on blood thinners, and there is some risk going to the operating room that they could bleed further. This paper was actually from our group from several years ago, showing that you can gain visual acuity either with anti-VEGF repeat injections or surgical displacement. The surgical displacement group regained that vision a little sooner.
Wow, what a great outcome. I'm going to go back to your post-op photo here. Just for the panel and for Avi as well, what are some risk factors for submacular hemorrhages for these patients who are at risk with wet AMD?
You know, Brad, one of the things when I see patients with really large PEDs or pigment epithelial detachments, they're at risk for RPE tears even with anti-VEGF treatment. So they may not present with a large submacular hemorrhage, but I do counsel those patients that, hey, even with this shot, we may end up in a bad situation.
That's an excellent point. I think, we're inclined to think that maybe an interruption in anti-VEGF may be a risk factor for these, and maybe it is in some cases, but absolutely right that sometimes that rapid contraction, even with the more effective anti-VEGF medication is, and it may actually be a bigger risk for sudden contraction of a core and vascular membrane and a rip and a subsequent hemorrhage.
And the other thing that is highlighted with my patients is I get asked often if Coumadin or anticoagulation cause these hemorrhages. And the discussion I have with my patients is they don't cause the hemorrhage, but it makes the hemorrhage you have much worse. So I think that's an important distinction as well, is the anticoagulation use itself won't result in your macular hemorrhage. It's really just, tenacious neovascularization that causes this.
And to bounce off that, Dr. Dang, if they are on blood thinners and they have a small, even non-central involving hemorrhage and they're asymptomatic, I push a lot harder for them to get anti-VEGF because we know that it can turn into a much bigger problem very quickly.
Absolutely.
What about uncontrolled or hypertension? Do you counsel patients on making sure that is not being left out as far as paying attention to their blood pressure in combination with blood thinners and wet AMD?
Definitely. And you run into this problem actually with some of these patients where they show up with a hemorrhage like on the left of the screen here, but they're not good surgical candidates because the rest of their health predisposes them to significant risk from the surgery, either uncontrolled hypertension or they're on blood thinners, and by the time we were able to go to the operating room and we've cleared the blood thinners away, the scar may have already started forming.
We've also experienced some instances with patients where they have just continued their anticoagulation for years and haven't touched back in with their physician in a while, their prescribing physician, and having the opportunity, like you mentioned, Dr. Hanasoge, with just an eccentric small hemorrhage, being able to mention to them, hey, can you please touch base with your prescribing physician, see if you still need to be on this medication. And it's not uncommon where when they do have a discussion with the provider, it turns out their risk is low enough that they can come off it. They don't need the baby aspirin. And sometimes even the Eliquis they'll remove because it was for some DVT years and years ago, and they no longer really need the prophylaxis. So I do find that a good time to touch base with those patients as well.
Important point. I think that this comes up with or without submacular hemorrhages on any patient who is on a blood thinner that we're taking to the operating room to make sure that an INR is checked with their primary care physician or treating physician or cardiologist, whatnot, to make sure both that it's not too high because we don't want to deal with uncontrolled bleeding at time of surgery, but also we want to make sure it's not too low because we don't want the patient to be at risk for stroke.
What do you guys do with these patients after you've cleared the hemorrhage? Do you continue to inject them? Do you tell them they've bought shots for life, or do you say it's cleared, it looks good now, and we'll just watch?
Avi, you nailed it. It's shots for life. And this is very hard for some of my patients who may have been quiescent for an extended period of time. But when anyone develops a hemorrhage, I say that's it. We're on maintenance injection. The only exception to this would be if a patient didn't have a great outcome like yours did. If they were hand motion pre-op and they had so much fibrosis, they stayed hand motion post-operatively. In those cases, I would consider whether injections are really a meaningful improvement to their long-term quality of life.
Question about baby aspirin. How do you guys feel about patients who have been told to stay on baby aspirin by their primary care doctor? Maybe they self-started baby aspirin. What do you do with those patients?
Self-starters, I always tell you, you got to talk to your primary care doctor because it's not a benign drug as available over the counter, but it still has significant impacts. But at the same time, if people have been prescribed baby aspirin by their primary care provider or their cardiologist, I kind of do a glance over at what their cardiovascular risk factors are. And if I've seen multiple MIs and all that, I think it needs to stay on.
Mm-hmm.
Okay, we'll go. We got one more case I want to show just to stay on time. So this is a patient with a history of retinal detachment. It's MAC off. He's been stable for a while, and now he notes blurred vision. And so in the patient's right eye here, you can see the IOL may be displaced a little bit. There's some phimosis to the capsule, and there's neovascularization of the iris. So this is a UDM looking at the position of the intraocular lens implant, and this is two different positions. On the left side, the patient is looking down toward the ground, and then on the right side, the patient is just looking straight ahead. So you can see that implant is confirmed to be a little wobbly, a little unstable, and probably hitting the iris and contributing to some chronic inflammation, sort of like an UGG syndrome with chronic neovascularization. So what would you guys do in this case?
I think with UGG, you have to, attack the underlying problem, that unstable lens. So I'd probably move forward towards the IOL removal. Talking about some options, some secondary IOLs, if we can suture those. In some patients, though, ACIOLs or aphakic contact lenses are a good option.
Agreed. I don't think if it's a mild hemorrhage and we've got some surgical constraints, sometimes I'll observe with a cycloplegic, like just put them on atropine, and I'm able to temporize the situation and prevent them from rebleeding. Anti-VEGF. This is a mechanical problem. You're literally getting hardware bumping on the inside of the eye. Drug is not going to do it. And then, like Dr. Blackerby said, if observation with cycloplegia is not an option, ideally you got to get the IOL out with aphakic correction or plan on a secondary IOL, sutured or AC.
Okay, good. So we'll go through this case quickly. So that's exactly what we decided to do, is just take the IOL out. And this is actually Dr. Wong, I believe, was working on this case. You can see him putting some iris tractors in because there was a little bit of dryasys or a miotic pupil with the neovascularization. Lifting the implant out, docking it there on the iris. He's going to complete the scleral tunnel here to take this out in total without cutting it, because we're planning on putting an Acryos lens in, trying to suture that lens in. And so we got it perched on the iris there, and it just kind of bumps and falls back. That's okay. We needed to just go ahead and make that wound anyway. And I think he put some viscoelastic in the anterior chamber just so that we don't harm the endothelium. He then makes another attempt, snags that IOL, takes it out without much trauma to the iris. Final inspection here, little hemorrhage there. And then this is where the fun with the spaghetti begins. So this is a scleral fixated Acryos lens using suture to the sclera. This is Gore-Tex, and this has been around for a while now. We've all been doing these cases for a while. I was kind of a late adopter in this technique because I didn't like the Gore-Tex sort of running along the scleral surface just underneath the conjunctiva. So we tried something a little different in this case. You can see us docking that Acryos implant in behind the iris. And so the difference here is just passing the Gore-Tex intrasclerally, so that hopefully we achieve a look at the end where there's no visible suture underneath the conj. I'm just going to go ahead and skip to that. We're doing the other side, of course. So here's the post-op appearance. I just wonder what the panel thinks about this. Is this even more acrobatics that are unnecessary for a lens? Should we have just put an ACIOL in, or a Yamane, or does this make sense? What do you guys think?
This is very slick, Brad. Always enjoy watching your surgeries and seeing the things you come up with. You mentioned a couple different things. I think ACIOL can be a good option for these patients, but if you've got somebody on the younger side, you want to think about corneal decompensation. And so, having something PCIOL can be good. I've done so many of these Acryos lenses, and I find Gore-Tex to be incredibly inert. So you can always see it underneath the conjunctiva. And long-term, I have not seen any problems with it. I've even had one or two patients where the conjunctiva has eroded, and they still are doing excellent. No irritation, no real problems with that. Yamane was something that I was very excited about because it can be very quick. I like the idea of just 2 sclerotomy sites for fixation, but the long-term data just wasn't there for me. I feel like the refractive outcomes with Acryos and ACIOL are just so much more superior to Yamane. Dr. Papakostas and I talked about Yamane as well, where it's just like if you look at Dr. Yamane's cases out of Japan, he's using Aura intraoperatively to help him adjust his lens tilt, because that's one of the big things. You can get this really challenging astigmatism induced by having the 2-point fixation and tilt. And practically speaking, that's just not something we have easy access to in the United States, because it is not a covered thing with reimbursement, and then it would be a patient out of pocket. And we have this excellent surgery with Acryos with 4 points fixation that eliminates that. So I'm Acryos or ACIOL all the way for these type of cases.
Very good. Okay, in order to stay on time, we're going to jump to Dr. Blinder's talk. Unfortunately, Dr. Blinder couldn't be with us in person today, but he's actually given 6 talks somewhere else, and he was gracious enough to record his talk in advance for us. So with that, Jennifer, I'll turn over you to play Dr. Blinder's video, who will be speaking about dealing with vitreous opacities, which is a significant issue for some of our patients.
Hello, this is Kevin Blinder. I'd like to thank you all for attending today our virtual spring retina update. I am sorry I cannot be here live virtually, but I am attending another meeting where I'm speaking. But I do want to thank Dr. Brad Smith and Nancy Blasky for setting this up, arranging the meeting, doing such a fantastic job year after year. And again, I'd like to thank all of you for attending here today. So my topic is dealing with vitreous opacities. These are my financial disclosures, have nothing to do with our talk today. So symptomatic vitreous opacities. Floaters have been cited by three of the classical ancient physicians, Hippocrates, Galen, and Avicenna. Early medical texts from civilizations like ancient India describe these phenomena as black flies in the field of vision. The awareness of floaters has persisted throughout history, becoming a subject of fascination for scholars and artists alike. So myodysopsia, or the perception of floaters, was first coined by the late 18th century Austrian physician Joseph Jacob Planck. Muscae volitantes is the Latin term meaning flying flies, otherwise known as vitreous opacities and also floaters. So evaluation of vitreous floaters begins with first ruling out any vitreoretinal pathology that it can accompany the vitreous floaters. Most common cause, of course, is a posterior vitreous detachment. This happens, vitreous degeneration happens to everyone if you live long enough. Vitreous is, of course, a gel-like substance made up of water and collagen that fills the eye behind the lens. Over time, the gel becomes less gel-like, more liquid-like, shrinks and pulls away from the retina. This is, of course, known as a posterior vitreous detachment. And you hope that it doesn't stay attached to the retina, certain area peripherally, and cause a tear, which can, of course, subsequently lead to a retinal detachment. So, again, you want to rule out any pathology with the companies that posterior vitreous detachment, retinal tears, detachments. It could be a sign of ocular inflammation and a newer entity and iatrogenic cause, silicone oil droplets that can occur post-intravitreal injections, which of course we as vitreoretinal surgeons do a lot of these injections, and we can use these syringes that are silicone that have silicone lubrication in the syringe for ease of injection. And we learned a while ago that these can lead to formation of silicone droplets in the vitreous cavity. Still can happen, still something to be aware of and acknowledge that this can occur. So the next step is, are these floaters visually significant? The patient in front of you, you have to ask, does this affect your daily activities, your daily life on a routine basis, or is this just something that affects you, once or twice a week, once or twice a month? You really have to see how much this is affecting the patient. And then there's imaging modalities that we can use to help identify these floaters: optical coherence tomography, of course OCT, dynamic ultra wide field infrared confocal scanning laser ophthalmoscopy, which not as used as commonly, quantitative ultrasound. So I think the most common thing, of course, that we use is OCT, and here you can see the floater scotoma. Definition is just producing a shadowing artifact onto the OCT image, and also the scanning laser ophthalmoscopy as well. I think a nice tool is with the Heidelberg using the infrared video and actually showing the patient what they're seeing. You show this in the room, and they say, "Yes, doc, that's exactly what I'm seeing." You can see how bothersome this can be, or "Oh yeah, that's what I see, and it's a lot smaller than I thought, and isn't really a concern." But here you can see how much it can affect the patient's life, having this floating back and forth all day long. A valuable tool, I think. So, it's a matter of, with symptomatic vitreous opacity, the quality of life issues. Razavi and co-authors in JVRD in 2024 looked at quantitative contrast sensitivity function tests, 232 healthy eyes, 80 with a posterior vitreous detachment. And what they found was the test in here found a statistically significant visual function deficit in eyes with posterior vitreous detachment that would have been missed with traditional visual acuity testing. So contrast sensitivity testing is something that we are using more and more commonly in a lot of studies, and also in the regular workup of patients with different symptoms. Garcia and co-authors AJO 2016 presented a single-site prospective trial of 28 eyes. 8 patients developed posterior vitreous detachment in one eye with prior normal contrast sensitivity function testing. There was a significant decrease in contrast sensitivity in each of these 8 eyes that developed the PVD. 12 eyes, control eyes, with 9 of those having a posterior vitreous detachment. The contrast sensitivity did return to normal in these 8 patients post-vitrectomy. So again, you can see that quality of life was affected, and it certainly helped them post-treatment. So another, again, modality that we should consider using on our patients. So what are the treatment options? Well, certainly most commonly is observation that we'll talk about, farce lane vitrectomy, and then also the YAG vitreolysis. And we'll go through each of these. But here's another one. Here's the Miracle Cure eye floater capsules made by Willow. And of course, there's many others. Eye floater wellness formula. Curatonics makes this. How about the Vitreous Health, Macular Health, 90-day supply, good bargain, eye floater treatment, the Hero Clear, and a more Vitreous Health made by Macular Health. So there's other agents out there. Certainly none of these have been scientifically proven to help, and can only hurt the pocketbook, in my mind. And I'm sure your patients are going to bring this up at some point, and we have to base our treatment recommendations on scientific evidence, which there's none supporting any of these products, just to mention. So again, my preferred initial option is observation. Monitor, reassure these patients. Again, you want to make sure there's no vitreoretinal pathology that you need to address urgently. But really, time is on our side in these patients. You know, gravity, neuroadaptation. I don't know how many times this happened where I tell the patient, you know, they're begging me to present them with a cure for their acute symptoms, and I tell them the majority of the time, within 6 months, maybe a year, you'll come back and you'll say, "Doctor, I'm so happy you talked me out of surgery. I'm totally normal now. I don't see any floaters." So the floaters either move out of the visual axis, or they learn to adapt, and the brain really learns to ignore these floaters. So time, again, cures most of these patients. So how about vitrectomy for removal of symptomatic vitreous opacities? I want to talk about a little nomenclature here, just a pet peeve. You know, we can call this floaterectomy, right? Well, a lot of people do, but I think it's a misnomer. Our goal here isn't just to take out the floaters. Our goal is to do a vitrectomy to remove the vitreous and include the symptomatic vitreous opacities. So I think we need to use better terminology, and I'll show you why. So old school, back in the day, you know, when I actually first started, the instrumentation wasn't as good, a lot cruder, and really the complication rate was a lot higher. So I would tell most of my patients, listen, you know, we have a treatment option, but you know, before you dive off the deep end and decide to end it all, come to me and we'll take care of it. That was our philosophy back then. But I think that's certainly antiquated. I think with newer technology, small gauge sutureless vitrectomy is a wonderful innovation. Transconjunctival, the biblade technology where the cutter cuts both ways, up and down, back and forth, cutting both ways. It certainly is such an efficient cutter now. And going down from, starting from 17 gauge, which we started with Macular's first cutter, to now our smallest cutter is a 27 gauge. So it's really come a long way. So here's the valve trocars, which has been a wonderful thing, where you have a valve on the cannula inserted with this trocar. You don't have to take down the conjunctiva anymore. You don't have to enter with a blade, MBR blade. It's all in one. Put the valved cannula in at the same time, and you don't have to worry about egress of fluids out of the eye, along with vitreous, causing vitreous traction, causing peripheral retinal tears. And then we're putting in the wide-angle viewing system. This is a ReSight. So again, wonderful innovations. So with that, the ReSight, and the other option is the Biome. This has led to a greater view of the peripheral retina during surgery, and to a much lower rate of retinal tears and detachments intraoperatively. Again, a safer thing, safer modality. This is the view without the wide angle system, viewing system, and here is, you can see, you can get out much further, and you can detect tears that happen during surgery. You can detect them, treat them there, and avoid a detachment postoperatively. So we have better technology, better innovations, but is the risk of surgery really worth the potential benefits? That's of course the bottom line, and I think a lot of people will say it is, and some will say it isn't, but I think the initial decision, of course, is up to the patient. But if we look at some of the data, this is the IRIS registry data. This is Rubino's study, Rubino and co-authors, 2020 Ophthalmology Retina. Through the IRIS registry, they looked at 17,615 eyes undergoing vitrectomy for symptomatic vitreous opacities. In their follow-up, they had 2,187 eyes, or 12.4%, returned to the operating room for cataract extraction. They had 643 eyes, 3.7%, returned to the operating room for a non-cataract procedure. And they had 457 eyes, 2.6%, returned to the operating room for a retinal detachment repair. So certainly significant number of return trips to the operating room in their series. And then a more recent series was presented by Chan and co-authors at the ASRS meeting in July in Stockholm this past summer, with IRIS registry data. Again, looking at a large number of patients, 42,047 eyes, 52.5% were female that underwent a parts-planned vitrectomy for symptomatic vitreous opacities, all within a year. Their occurrence complication rate was vitreous hemorrhage of 26.3%, a little higher than I would have anticipated. This is any vitreous any hemorrhage in the vitreous cavity that occurred postoperatively. Retinal detachment 4.2%, again a little higher than I would have thought, and endophthalmitis rate a lot higher than I would have thought, at 3.7% through the IRIS registry data. 16.8% of these cases were non-retina specialty, performed in a non-retina specialty practice. Something to consider also if they weren't properly trained to really do these cases or not. So my rules for vitrectomy, once the patient has decided to undergo surgery, is number one, you have to do a complete vitrectomy. Again, that gets away from the terminology fluorectomy. We're taking out the vitreous, as much vitreous as you can, which includes the vitreous opacities. So one way to confirm this is by using dyes during the surgery to confirm that the posterior hyaloid face is elevated. Kenalog is probably the preferred choice because it's works well and low cost. Now, if you don't elevate the hyaloid intraoperatively, still down, this can lead to recurrent vitreous opacities postoperatively. And that leads to certainly unhappy patients. Boniva and co-authors in Retina 2023 published a series looking at recurrent central floaters that occurred post-vitrectomy in 14.1% of their patients, 14 out of 99 patients, that did not have intraoperative posterior vitreous detachment induction during surgery. So one way of telling if the posterior hyaloid face is elevated is by using a brilliant blue G dye, which is we use very commonly now to stain the internal limiting membrane in pucker cases and macular hole cases. But it's also very useful to detect if the posterior hyaloid face is elevated. So once you've done your core vitrectomy, you inject the blue, and you see if the posterior hyaloid face is elevated, and certain signs to detect if it is or isn't. So here you can see with the cutter, you're going down, aspirating here, some of the dye is coming up, but then you see that a lot of it is adherent to the posterior hyaloid face, and you're pulling here, and you can see the hyaloid is still down, and you want to re-engage the posterior hyaloid face with the cutter on aspiration. You're pulling up here, you can see that some of it is coming up, still a little reluctant to come, and this may take a few tries to get the hyaloid up, but again, it's worth the effort, because if you don't, it's bound to separate later on, and then again this will lead to recurrent vitreous opacities. And then here you can see we got it. You can see the Weiss ring here, and then you just go and elevate a little more. You want to, of course, not use aspiration, pull it up all the way to the vitreous base. That can lead to iatrogenic tears. So you have it elevated. You can see there's a lot more vitreous now because it's all elevated from the surface of the retina. And then you're completing your vitrectomy and going more peripheral. You can see the edge of the posterior face here and bring it out more peripherally. So again, a nice technique. I like blue. When I use it more commonly when we're going to do a peel or a macular hole repair, because you're opening up just one substance, using it for two functions. But for this case, I think it works very well. Here's the triamcinolone Kenalog injection. Again, we've already done our core, so you want to see if the hyaloid's still down or not. I think that this is a wonderful way of testing. You can see here that indeed the hyaloid is still down. You can see the Kenalog just kind of sits on the hyaloid face and comes up very easily. First try. And you can see the Weiss ring, which I will show here. Tell that's up, and then of course then you finish the vitrectomy at this point. So another rule, personal pet peeve, vitrectomy should be done by vitreoretinal surgeons who can deal with the complications. Maybe easy enough to go in and take out the opacities, especially if the posterior hyaloid face is already elevated. You don't have to deal with that, but you want to be able to deal with occurrence of retinal tears or detachments intraoperatively or postoperatively. And again, it takes our fellows 2 years to learn how to deal with those complications. And then scleral depression at the end of, I recommend that for end of every case, but it's crucial. You want to, again, detect anything that's going on intraoperatively and avoid another trip back to the OR. So here's a case that Dr. Jake Anderson, one of our second-year fellows who will be staying with us, joining us in the fall. It's doing a nice case here. See, doing the core vitrectomy, and you really see the vitreous well. I mean, it's just a nice a visualization of the vitreous. See the cutter, the light pipe. And again, injecting the Kenalog. Any bets here? Is it up or down? It's up, because you see all the Kenalog moving around freely, not staying adherent to the posterior face because it's already elevated. So at the end, we want to depress, and lo and behold, you can see a little retinal hole right there. And maybe this won't lead to detachment, but the vitreous is removed. There's nothing blocking it now, so there is a good chance it could lead to detachment. So it's better to visualize it during this case. You're looking around, there's another hole there, hard to see because of the glare of the light. But then we treat it appropriately with the endolaser photocoagulation. Seal it down before it can cause any other problems in this patient. Treating this one over here. And then we're going to air. We're going to leave probably a short-acting gas tamponade to make sure. And here we're leaving gas. We're doing the mixture of the gas through the infusion line and then extruding out through this cannula, and then we get it to the certain level. And you see, it's so easy. You pull out the valve cannula, no leak evident. We're looking for leaks. No suture needed. Just a nice system. Nice job, Jake. So, this is a PAT survey that is sent out to retina specialists domestically and internationally. The Preferences and Trends membership survey that we do every year through the American Society of Retina Specialists. This is in 2024, and the question here was, we like to see what are the trends in our subspecialty. What is your surgical technique for vitreous opacities in a phakic eye with an attached hyaloid? So, majority of the time, perform a complete vitrectomy, ensure posterior hyaloid face is elevated. That's just what I was saying here, U.S. and internationally. Perform a core vitrectomy to remove only floaters, floaterectomy, again, cross out that term. But here, not a lot of people recommend that. Attempt to elevate the posterior hyaloid, but only if it's easy and safe. Well, unless it's really like a teenager, and you'll be able to get it up pretty easily. And you shouldn't be doing floaterectomies on teenagers anyway. Excuse that. You shouldn't be doing the vitrectomy for removal of symptomatic floaters, symptomatic opacities in a young patient. And then I do not perform this type of surgery. This is not something that all retina specialists offer. And again, in the right scenario, right setting, right patient, we feel that we can offer it to our patients in a safe fashion. So, patient satisfaction for this surgery is very high in most trials. There's, again, improved contrast sensitivity, reading speed post-vitrectomy, and then there's improved visual function questionnaire scores post-vitrectomy, the VFQ 39 and VFQ 25. So these are some of our happiest patients. Again, they come in extremely symptomatic. They have to have that requirement to even consider surgery. And many times post-operatively, they do extremely well. They're very happy, and they want the fellow eye done ASAP. Happy patients. I should note also that we do not get rid of the glasses in this surgical procedure. Just to note, no promises there. So what percentage of your patients, another PAT survey question, what percentage of your patients who complain of vitreous opacities do you eventually take to surgery? Again, it's not high. We have a lot of patients that complain about this. Again, the first treatment choice, observation, most of them are cured with that. It's a small percentage that actually end up going to surgery. Now, how many vitreous opacity surgeries do you perform on an average each month? This is actually in 2022, so I think it's been going up, but 1 to 3, is probably the most 0 most common, but 1 to 3 the second most common each month. I think that's probably the high estimate for actually me personally, but I think it's becoming more and more common that patients are bothered by these opacities, and I think in this day and age, people are actually looking for perfection, and certainly get it a lot more with cataract surgery. So much of the time they do great. The multifocal IOLs, everything is just a notch higher than it used to be, and certainly in our realm as well, they're looking for cures and perfection. So what else can we offer our patients? Well, there is YAG laser vitreolysis. It's less invasive, better for a limited amount of floaters, and may require multiple laser sessions. It's not something that I recommend at this point. Biggest reason is a lot of times you're taking a few large floaters and you're making them into many small floaters with the laser. And there's also a risk. But Payman was the first one to recommend or consider this notion in 1984. Tsai was the first one to present a series of cases in 1993. See the references. Shaw and Hyatt performed the only randomized clinical trial on laser vitreolysis. In 2017, they had 52 patients with symptomatic Weiss ring PVD randomized to YAG vitreolysis versus sham, six-month follow-up. The YAG group reported greater symptomatic improvement, 54%, than the controls of 9%. A total of 19 patients, 53% in the YAG group, reported significantly or completely improved symptoms versus 0 in the sham group. And this was statistically significant. And no differences in adverse events between the groups were identified, but there is a complication rate risk in doing this procedure. Here you can see, you're aiming the YAG laser at these vitreous opacities. You want to get the ones that are too close to retina. That can be a risk. You don't want to get too close to the lens because there can be a risk of lens damage as well. So there are complications that have been reported in the past. The difficult thing is the long-term safety and efficacy are lacking because this has not been around that long. Various complications have been reported. Shields and co-authors reported 2 cases with complications that they had. First developed a vitreous hemorrhage and subsequent branch retinal vein occlusion. The second patient developed a temporal scotoma from a full-thickness retinal break with a subclinical retinal detachment that you can see here, the break and some fluid beneath the retina. You can see the site here, the posterior pole. So hemorrhage, retinal holes, CME has occurred, intraocular pressure elevation, and other less common complications. So I think we've discussed a lot here today. I thank you for your time. This is something, again, that we offer, to our patients that are, again, fit the criteria that we discussed. And Primin, non nocere, of course, our first rule. First off, do no harm in our patients, and we do what we think is right. So again, thank you for your time, and I am not open for questions, but my partners are, and you can also ask me questions anytime at kjblinder@gmail.com. Always happy to help out. Thank you.
Well, we thank Dr. Blinder for the presentation. Obviously, we miss having Kevin here live. We did have some questions that came through the chat. Kenalog, could one of you speak to how we use Kenalog to visualize the vitreous?
Sure. So I tell my patients Kenalog, in layman terms, kind of like putting snow in a snow globe. So I'm putting it in to visualize something I can't see. And as we saw when Dr. Blinder lifted the hyaloid, we can see the posterior hyaloid very well, but also in the periphery, the movement or the lack of movement of those little Kenalog granules can tell me what vitreous may remain that I otherwise couldn't see.
I love how many analogies we have for catalog, and I love yours one with the snow globe. My mentor used to say that it's like putting a blanket on a ghost. So vitreous is a ghost, we can see it, and the catalog is a blanket that we can cover it. So it's a mechanical particles that are coating the vitreous. But I will add yours as well to my repertoire when explaining to the patient.
Excellent. I think we have time for one more question. How long would you guys wait, ask the patient to wait and observe before proceeding with surgery? Are there times when you would not make them wait?
I think it's an excellent question. It really depends on a patient, right? It depends how long have they been symptomatic. If they present with acute PVD, it's no surprise that they're very bothered by their floaters. And in that case, I would reassure them that, there's a good chance that, as Dr. Blinder pointed out, that the floaters will become less symptomatic with time. And in that case, I'm more likely to observe, and I will be observing them closely because we're looking for any peripheral pathology, retinal tears, detachments. But if somebody has been symptomatic for some time, I usually would like to meet them at least twice so that the first conversation is explaining their pathology and providing them options of management, and then giving them information to take home and discuss with their family. And then a second appointment would be the one if they want to proceed with surgery for a sign-up. What about you?
Usually 6 months, because a lot of people come in acutely symptomatic from a new PVD, and I find 6 months is the sweet spot where they narrow habituate to it and they just don't really notice it as much anymore. So I find that my need for surgery goes way down if we can just wait it out 6 months. But every now and then you get somebody where you're like, we know that floater's not going anywhere. It's this giant like Goomba right over their macula. They're probably at risk for car accidents, or they may have a job where that interferes with their ability. And yes, obviously that needs to be done. There was a question that I'm just going to reference real quick. Someone asked, why do we have to take out all the vitreous? I'm going to say for myself personally, if I'm going to go in and commit somebody to the risk of surgery, I never want them to have to come back. And so we want to get that all cleaned up and make sure that all the vitreous that we can remove is gone so they can have as clear vision as possible. And to stay on schedule, I'm going to throw it back to Dr. Smith, who's going to lead us in a discussion about some exciting new technology, photobiomodulation.
Thank you, Sabine. Dr. Blinder, thank you. So Dr. Blinder actually talked on this subject about 2 years ago at this very conference, gave a wonderful talk about how DRCR was studying this, and there's been tremendous developments since then. In order to set this session up for discussion, I just wanted to share a case of a patient with severe vision loss in the left eye from a past submacular hemorrhage and fibrosis. So, and in their right eye, I'm just playing a video that just demonstrates that over the past year, drusen indeed can change, they evolve, they can accumulate more, they coalesce, and they sometimes will go away. So with that in mind, we'll go to this other background where laser or laser light to drusen in order to reduce drusen load is not a new thing. It's not a novel concept. Even 20 years ago, there was a laser to drusen trial using 810 nanometer wavelength laser to treat drusen, and it indeed worked. But unfortunately, there were some association with an increased risk of choroidal neovascular membrane development. So a new technology has been developed by Lumitherapy called the Valida device. And this is not the actual device. This is just a little bit of fun here. You may recognize Light Bright from the 70s and 80s, but can it be as simple as this, where we just have patients with this horrible disease? And keep in mind, even in 2019, nearly 20 million Americans were noted to be suffering from some form of macular degeneration. So this would be huge if it works. And this new device by Lumithera uses 3 different wavelengths, an 850 nanometer wavelength, 660, and then 590, which is sort of like an amber light. And this is an example patient from the LightSight trials. There was 3 of them. Most recently, the LightSight 3 trial was published last year. And this patient is an example of some almost miraculous improvement in drusen load. So it seems to work in some patients. And I've just got this data showing it, and I just want to turn it over to the panel. Like, what do you guys think? What are you saying to patients? Does this work? Is it too early? Take it away.
For me, the technology is a little bit early. I always love looking at new ways to treat patients, especially less invasive ways. So it's interesting, but the study had a few limitations for me. It did have a high dropout rate, about 25% in the sham group, about 14% in the other group. And both groups did experience visual improvements. So you wonder, is this a placebo effect? Most of the visual recovery was in the first month of the trial. So is that a placebo effect there? Is it a regression to the mean, a statistical irregularity? I think it's interesting technology, but I do think we need to learn a little bit more about it before I institute that in my practice.
This was definitely a very elegant study, and we get so excited for any treatment options because there's none right now for the early stages of dry macular degeneration. So I love, Dr. Smith, that you brought this to our attention and for discussion because there is a huge need. We want to intervene early. We want to try to help patients before they progress. And the way that was designed, it's very, very smart. I do agree with Dr. Blackerby that I would like to see more patients enrolled than it was for this study, just to see what are, to have greater power so that we can interpret the results better. There's also some additional information that I would like to know about how exactly the therapy was performed as far as the pupil size, the dilation, lens status. All of this data would be really important when we actually begin to treat patients. So there are a couple of limitations that I would just like to see a little bit more information on.
Do you guys view this as a risk-free treatment?
Yes, it is a risk-free treatment. Yes, that's the nice thing about it. There are no complications compared to other treatments with dry AMD that have, more serious issues. In terms of efficacy, I will echo what was said before. It's a little bit early to tell. There might be a small signal, but based on this data, I don't think you can say with a high level of certainty that this thing works. But on the other hand, it's safe. I mean, it's essentially light. We haven't seen any adverse events with that.
And I think to piggyback off that with the safety, if this is something that can ultimately be a device that is created low cost that a patient's able to do at home as opposed to something that, the patient has to come to clinic. I know the burden of coming to clinic often for treatments is quite high for some patients. So I certainly am very encouraged by the results. I do hope there's further study and research because this may be something that can be a cost-effective treatment that patients can actually do in their home, which we don't really have very many treatments like that in our field. So I'm encouraged and hopeful to see more data on it.
Just the risk, I think it is a low risk treatment, especially compared to some of the other things we do for patients, particularly anti-complement injections for geographic atrophy, which we'll highlight a little later today. But, this photobiomodulation therapy for retinal disease, it's not new. It's been used in China to treat high myopia. And there have been some associated case reports. Now, perhaps they're isolated. Perhaps there's some other things that were going on. But in particular, a young patient was reported on, a 12-year-old girl, I believe, who had some significant photoreceptor atrophy and lost vision from light therapy. And then even in the LightSight trials, the treated group, they did have a higher rate of conversion to choroidal and vascular membranes. Now, does that mean it was caused by the lumitherapy device? It's just too small to make assumptions one way or the other. So hopefully time will tell. Definitely longer follow-up will give us a sense of whether or not it is low risk, which I think it is, and I certainly hope it is, because we need something. Our patients need something.
I think there's also a potential down the line that somebody's going to create some bootleg device and put out some UV wavelengths into people's eyes and fry their retinas or their lenses. So I think there's some risk there. And then the other risk, you're right, it's not a risky thing to have this light, but I think the biggest risk is there is some risk every time patients get in a car and drive to our clinic, like Nick Ife was mentioning. There's some chance they get into a car accident. So if you could get this at home, it's probably safer. And then there's a risk of disappointment. You're paying potentially a lot of money for something that may not work.
I think the other thing that will be interesting to find out is, are these benefits that we're seeing, are these short-term benefits or long-term benefits? Do these patients need to stay on this treatment indefinitely? Or are they going to lose this ground that they may make up with receiving the treatment? So kind of like others have alluded to, I think it'll be interesting to see more robust and more long-term data.
Very good. Okay. Anyone else have any comments about photobiomodulation therapy?
I think
Can you
similar to the myopia studies, it's one of the articles that definitely encouraged me to go outside and experience the natural sunshine, right? It's not only good for slowing down the myopia progression, but maybe it's also good for, preventing drusen formation or.
Yeah. Yeah, good point. Yeah, just sunglasses with the appropriate blockade of
Filter.
the shorter wavelength of radiation waves like UV and, of course, shorter wavelength blue lights, but maybe gate in those lower wavelengths. So spending time outside, I like that. That's cheap.
Exactly. It's free, risk-free.
Yeah. All right. Well, certainly, if there's any more comments, please do say them or have any questions. And as we do that, we'll transition to our next talk given by Dr. Barton Blackerby on the topic of optical coherence tomography angiography.
Well, thank you, Dr. Smith. So I'm going to be talking about a dry topic, I think. Imaging is always a little bit dry, but we're going to learn about a few medical conditions along the way. And one of these newer things that we talk about in terms of reimbursements and images in the clinic that is very useful. Disclosures are limited in here. So let's talk about the basics of OCTA angiography. So OCTA technology uses laser light reflectance on the surface of moving red blood cells to accurately depict vessels through different segmented areas of the eye. So the OCT scan of a patient's retina consists of multiple individual A scans that are compiled into a cross-sectional structural image, kind of a 2D and sometimes 3D image. With OCTA technology, that same tissue area is being repeatedly imaged and differences are analyzed between the scans over time, allowing one to detect zones containing high flow rates, which are marked changes between the scans, and zones with lower or no flow at all, which would be similar scans with each sweep. OCT and OCTA use different wavelengths, the near infrared, about 800 nanometers, another one about 1050. So perhaps we're doing a little bit of some photobiomodulation here every time we see them in clinic. OCTA employs two methods for detecting motion. We're not going to get into the details of this. I just mentioned them, so if you read papers on these, you kind of know there are different ways that we can formulate the image, and that is amplitude decorrelation and phase variance. The former detects differences in the amplitude between the two different scans. Phase variance is related to the emitted light wave properties and the variation of that phase as it intercepts those moving objects. But in total, these algorithms create an image typically about 3 to 12 millimeters square that is segmented into about 4 zones: a superficial retinal plexus, the deep retinal plexus, the outer retina, and the choroid capillaris. So let's look at those with a little bit more depth. So in this image here, we see on the left cross-sectional view of the retina. It's divided here, color-coded into the various layers of the retina. But what's more importantly is what's on the very left-hand side of that image. And we see in the inner retinal circulation, we have three different capillary plexuses. We have our superficial, we have our intermediate, and we have our deep capillary plexuses. We have an area here, which is the avascular zone. We shouldn't find any vessels within the zone. And then out here, we have the vessels, the chora capillaris. When we look at an OCTA image, especially that en face image, we do see three different vascular networks of that inner retinal circulation. And that's that superficial, the intermediate, and deep capillary plexus. And the very center of that image is our foveal avascular zone. So we're going to compare this technology briefly to the gold standard that we've always had, fluorescein angiography or ICG. This imaging is great. We use it very frequently in retina. It produces this 2D image, and it's able to show us dynamic visualization of blood flow, which we can't see in an OCTA. This can show us pooling, staining, leakage, but sometimes this flow can obscure the finer details of whatever pathology we're looking at. An advantage is it gives us a very wide field view. So in cases like diabetic retinopathy, we can see far out into the periphery. But sometimes it's a little bit hard to localize pathology. So the identification and the location of that pathology requires us to understand various patterns of blockage and leakage from this technique. There are a few limitations of this. It's invasive. It requires a needle stick. It's time consuming. It takes a bit for our photographers. It can be expensive with the dyes. And there can be some adverse reactions. Some people can vomit. Rarely can somebody have an allergic reaction. And we can't use it in all patients. So it's contraindicated in patients with ICG, with severe kidney disease, or in pregnancy. Talk a little bit about the advantages of OCTA. It's quick, takes about 6 seconds, and it provides structural and functional information together. So we'll see in our cases how we can really localize where the pathology is. It's not perfect though. There are limitations of this. It shows us a small area, typically right within the macula is where we look, although we may look at some other areas as well. We can show and interpret flow, but we can't actually show true leakage. And this is getting better with our newer algorithms, but you can have some image artifacts, ghost images, projection artifacts as the light gives us some shadowing to the deeper layers from the more superficial vascular plexuses. If the patient moves a lot, we can see a motion artifact, and we may miss some flow if it's very slow. And just like FA, we can't see through the hemorrhage. So let's talk about a few cases. So case number one, we have a 6-year-old female presented with new vision loss in the right eye. She had a diagnosis of wet AMD. A figure A up top shows an OCT with a solid appearing PED with a little bit of some overlying subretinal fluid. She was given an anti-VEGF injection, and then the fluid went away, as we see in figure B. The lesion appeared inactive on our exam. In the OCT, we see a little outer retinal tubule that we see about right here. These are often found in chronic and inactive lesions. These outer retinal tubules are the result of an arrangement of degenerating photoreceptors, and we can see them in a lot of different pathological states, especially in AMD. In OCT alone, these can appear as persistent intraretinal, maybe subretinal fluid, and they may be misinterpreted, leading to unnecessary interventions. So we decided to get an OCTA on this patient. We see that here in figure C and D, and this shows a large vascular network with a central ingrowth site. We can kind of see down here at the center of that tree, and some small capillaries at the edge of the lesion, despite the fluid being resolved. This finding in OCTA suggests that this lesion may continue to leak, putting the patient at a greater risk for vision loss. So though appearing inactive, the patient did receive treatment, given the immature appearance of the CNVM on the OCTA. And let's talk a little bit about why that's the case in this situation. So this case highlights the evaluation of CNVM ingrowth patterns that we can see on OCTAs, and it can aid in the prognosis of this condition. So previously studied by Al-Sheikh and colleagues, they examined eyes with type 1 CNVMs in AMD to determine immature or mature characteristics of these complexes. Immature and active CNVM complexes were described as having radiating vessels, kind of that Medusa or sea fan look that we saw in that prior image, extending from the central area of the lesion. You have arborization, this branching of these small vessels seen throughout the lesion, as well as peripheral vessel terminations. And this branching of these small vessels was seen to occur more frequently in active lesions, and it didn't decrease after administration of anti-VEGF. However, branching was decreased in quiescent lesions. So I think of this as like the dead tree that's lost a lot of branches, but the trunk and major branches remain. Additionally, that prominent vessel was seen more frequently in that quiescent group, and the radiating vessels appeared more dilated and straighter, similar to that dead tree analogy. These closures and less urbanization with that prominent central vessel provide some important prognostic signs concerning how long this lesion's been there and how responsive is that going to be to anti-VEGF therapy. Such findings are important because anti-VEGF therapy to mature lesions with these findings, it doesn't work as well because these have these protective parasites that prevent treatment from working as well. So let's move on to that next case we have. So we have a 79-year-old female presented for evaluation of macular degeneration, recent changes in her left eye. So we see here up top at figure A, the OCTA or OCT confirmed its irregular RPE complex, suggesting a non-exudative AMD in the right, and then on the left, the PED suggestive of a CNVM that we see there in figures B and D. OCTA confirmed a CNVM in the left eye that we see there in figure F. However, it also revealed a subclinical CNVM in the right eye that we see here in C and E, corresponding to that area of irregular RPE, even though there was no fluid. The patient was treated with sequential anti-VEGF injections beginning in the left eye, but also proactively treating the right eye. And subsequent studies that we see down below in H for the left eye, G for the right, showed a decrease in size and activity of the CNVM bilaterally. So the treatment of quiescent CMs is a little bit controversial. However, it may be considered in a patient with bilateral disease after a full discussion of the potential risk and benefits of that. In our case, the presence of these lesions did not necessarily require treatment, although the patient did want to be more proactive at preventing vision loss in the better seeing eye due to moderate vision loss in the left eye. So this case demonstrates the ability of OCTA to detect non-exudative quiescent CNVMs in patients, and it allows us to provide a more customized treatment and better follow-up for those eyes. Let's look at this next case here. We got a 73-year-old male presented with macular degeneration with an active CNVM in the right eye, and he was treated with photodynamic therapy. So the patient's PED appears heterogeneous on its OCT that we see here in figure B on the left, but it's better characterized by an OCT-A, which we see in figures A and C, as an occult CNVM that we would see on conventional fluorescein angiography. This case highlights how OCTA can further define the lesion and reveal characteristics of these components. In addition, OCTA flow was not masked by the pooling that we would have seen in fluorescein angiography, and it better allows us to see this lesion in detail. And this can directly influence our patient's treatments with PDT and anti-VEGF, because as stated before, we can see those fine changes within the CNVM. OCTA has shown merit with regard to evaluation of these PEDs. They're more commonly seen with AMD, but we see them in other conditions in which the blood-retina barrier is disrupted. Information by OCTA can influence the decision to provide PDT. So when we looked at the TAP and VIP trials, FA criteria was very specific on who would benefit from that, and it heavily relied on the interpretation of this that we can see very well with an OCTA. Through OCTA, that morphology is better defined because we're not getting that masking of the pooling effect in a PED. And it's allowing us to focus the PDT directly on where that feeder vessel might be, improving our success with that therapy. So let's take a look at a patient who did have PDT. We have a 70-year-old male who presented with decreased vision in the left eye. He had a history of requiring anti-VEGF treatments. Exam of the left eye reveals some ellipsoid zone and RPE atrophy. We can see that there in that picture in figure A. OCTA segmentation further defines these changes by noting some subretinal hyperreflective material within the overlying subretinal fluid, which we see there in B, or intraretinal fluid in B. OCTA confirmed the presence of a choroidal neovascularization with a well-defined ingrowth site and immature capillary fringes that we see there in C with the arrow pointing to that ingrowth site. PDT was directed at that site in an effort to decrease his dependency on anti-VEGF therapy. And what we see after PDT in figures D and E is that we see less overlying intraretinal fluid, reduction of the caliper of the feeder vessel, less branching, and reduction of those fine capillaries. So we're seeing that this CNVM has become more quiescent and mature. Several studies have reported on the regression of CNVMs after treatment of that identified feeder vessel with PDT. The identified the identification of this vessel is typically seen with ICG and only with the success rate about 22%. So we have to get better than that. But once we identified that, we were able to focus that PDT exactly on that area. And OCTA allows us to better define these areas so we can go directly at the site, as we saw in that prior case. PDT, though, as we know, it's largely been replaced by anti-VEGF therapy, but OCTA may allow for kind of a reemergence of the therapy through better preoperative planning for these patients. So let's move a little bit beyond just AMD. So in this case, we have a 37-year-old female who presented with a central scotoma in her right eye following a cold. Examination of the eyes, you see A and B here, shows a decrease in the foveal light reflex in the right eye with some subtle retinal whitening, and the left eye appears normal. OCT of the right eye demonstrates subfoveal neurosensory retinal detachment with increased reflectivity at the level of those photoreceptors. We see that there in figure C, and D appears normal. OCT of the right eye revealed normal perfusion of the superficial and deep capillary plexuses, which we were not showing in this slide. However, segmentation scans through the choriocapillaris, which we see down in E, show areas of hypoperfusion at the center and periphery of that detachment. Normal flow was observed in the left eye. It's possible that this increased hyperreflectivity of the neurosensory retinal detachment may inhibit accurate assessments of these deeper layers due to some of these artifacts. However, closer inspection of this case confirms the area of hypoperfusion we see on OCTA to be peripheral to any artifacts seen in the OCT images. So this tells us that there's probably some ischemia there beyond just that artifact alone. So follow-up blood tests were obtained in this patient to evaluate for the presence of Coxsackie titers, and she was positive for these. The patient was diagnosed with unilateral acute idiopathic maculopathy, given our clinical findings here, and recent association with the Coxsackie infection previously reported in the literature. So OCTA does have a role, as we see in this case and some others, in the role of posterior uveitis. While we can't dynamically detect inflammation and leakage, it can assess these other important associations of inflammation, such as the development of a secondary CNVM or ischemia. The lack of the ability to detect leakage may in fact be a strength of this technology in particular scenarios, because leakage on FA can obscure these deeper retinal vascular plexuses where some of this ischemia can occur. Findings such as dropout of parafoveal capillary density, flow deficits within these capillary plexuses, or capillary microvascular remodeling have been seen in areas of current and prior vasculitis. And with the help of OCTA, these hypofluorescent lesions we see in these placoid disorders that we may see with like ICG, we're able to better localize exactly where this is to the level of maybe the RPE or the interchoroid, and provide better patient counseling and prognostic factors for them, and kind of their overall visual recovery. So this is a great case that kind of wraps both these up together. So we have a 40-year-old patient, highly myopic female, presented with macular lesions in the left eye consistent with punctate interchoroidopathy. So let's talk a little bit about this condition, because it kind of has both of these characteristics in it. So PIC is characterized by multiple yellow or trophic levels at the level of the RPE and interchoroid, in the absence of any sign of inflammation elsewhere in the eye. On FA, these lesions are typically hyperfluorescent in the arteriolar phase and staining in the AV phase, and CNVMs appear as these focal areas of this irregular, maybe this little lacy network of neovascularization. With this condition, both CNVMs and inflammatory lesions present similar to it, and it kind of shows an elevation of the RPE, may show a little bit of some subretinal fluid on OCT and some leakage on the FA. OCT, though, it really shines in this condition because it's better suited to help differentiate these findings by analyzing the deeper vascular abnormalities and reorganization that may be seen with a CNVM. Distinguishing between inflammatory lesions and CNVMs is crucial because obviously for CNVMs, they respond to anti-VEGF. For inflammation, we need to treat those with steroids. So let's focus back on this patient and see what was developing here. So this patient's previous FA showed areas of leakage and inflammation, and she was initially treated with oral prednisone. At the follow-up, her vision had worsened, and clinical exam showed a new lesion under the fovea, suggesting a CNVM. We see here in figure A. FA is repeated, showing some hyperfluorescence within the lesion during the AV phase that we see here in figure B. And then we see this increasing hyperfluorescence in later frames that we see here in figure C. So we see this area here just getting more and more leakage. OCT shows the subretinal hyperreflective material called that shrim without any intraretinal or subretinal fluid that we see here in D. However, we got an OCTA that confirmed the hyperreflective material as well as a CNVM that was well demarcated that we see here in figure E, the sort of this lacy network we were talking about. So the patient was subsequently treated with anti-VEGF therapy, resulting in a reduction in size of the shrim and regression of the CNVM that we see here on figure G. So this case shows how the inability of OCTA to demonstrate leakage or staining might become an asset in these cases with inflammatory material, fibrosis, or a CNVM without fluid that can cause similar findings on OCT. So our next case, let's talk a little bit about no uveitis itself, but somebody came in with some blurry vision, getting prepared for cataract surgery. This is a case of a 39-year-old female with a history of sickle cell, recent sickle cell crisis that required hospitalization, came in for a cataract clearance. OCT shows thinning of that neurosensory retina in each eye, but OCTA is better able to define the reason for vision loss. And we see these abnormal areas of expansion of the foveolar vascular zone here, more seen on the right than the left in figure C and D. So the possibility of a reduced vision secondary foveal ischemia was discussed with the patient, and that helped prevent a potential postoperative surprise of suboptimal improvement in vision following her cataract surgery. So OCTA can be useful in signs and cases of diabetes and sickle cell retinopathy, where we're looking at changes in these capillary networks. In sickle cell retinopathy, signs of prior acute pre-capillary occlusion may be a loss of these interretinal layers, whereas signs of chronic posterior pole ischemia can show this this enlargement of the foveolar vascular zone, enlargement of the arterioles that we see there in the prior case. A study by Murphy and colleagues did look at this and focus on the evaluation of macular OCTs as a tool to identify not only foveal ischemia but peripheral ischemia in patients. In this study, OCT did reveal thinning of that temporal intermacular layers due to chronic ischemia, but then they looked at this with an OCTA and were able to see that there were changes within that foveolar vascular zone. So even though they didn't have the tools to look far out in the periphery for ischemia, they were able to show that that is a helpful hint that there may be ischemia in the periphery, indicating the need for an FA. Even after cataract surgery, OCTA can be useful. So this is a patient with post-op CME. The 63-year-old patient came in with decreased vision. Examination revealed some CME, very common after cataract surgery. But we also see maybe a little juxtafoveal microaneurysm that we see here in C. OCT demonstrated this little bit of some VMT on the right eye, the cystoid spaces, and that little hyperreflective dot that we see in the other eye. But OCTA was better able to define this because we're able to see flow through that lesion, suggesting it's not a microaneurysm, but likely a retinal angiomatous proliferation, or also known as type 3 CNVM that we see there in figures D, and then focus there on figures figure C and D, but D you can really see the little hot spot that's there. So OCTA is useful to see exactly what's going on here. This patient was treated with anti-VEGF therapy instead of postoperative NSAIDs and CME, which would have been the wrong treatment for this. And you can see that over time, that CME starts to resolve. You see that little wrap lesion start to get smaller as well. So for our last case here, this is one of JXT, close cousin of macular degeneration. This is a case of a 52-year-old female presented with these cystoid changes, these vascular anomalies in the temporal retina consistent with JXT. OCT shows these cystic spaces, some hyperreflective spots within that neurosensory retina that we see there in A and C. OCTA, though, highlights vessels with that mild dilation, abrupt termination, along with some capillary dropouts that we see in figures B and D. Neovascularization was ruled out without us having to use anything like FA. And it's another great clinical scenario where leakage may have confused our ability to rule out a CNVM, and demonstrates that OCTA, in terms of that small amount of flow we see, but obviously then not blockage that of these fine details we'd see in FA, can help us make the right decision. In these cases, some of these cystic changes, they're not due to CNVM, so we would not want to treat with anti-VEGF therapy. that we may have been fooled just with OCTA alone, thinking that maybe this is macular degeneration. So OCTA continues to evolve. We're going to see faster scanning of that. We're going to see wider field OCTAs coming to the market. It's going to be a better assessment of patients with diabetic retinopathy or retinal vein occlusions, AI integration into this to really help localize exactly what's going on and focus this on fine-tuning the diagnosis of what we see. And sometimes these early detection and monitoring of the disease. So for our diabetics, our macular degenerations, we've seen that we can detect things before they cause problems. And that's a true goal of medicine, is prevention is the best medicine. So this is going to help us see those, and we can provide some customized treatments. So I appreciate you guys listening today. I hope that this is able to give you confidence to integrate this technology into your workflow, and open for any questions. Thank you.
Wow. Thank you. Thank you, Dr. Blackerby. That was a lot of information. Indeed, OCTA does supply us with a lot of information about the retina. Just a question I wanted to pose to the panel. How are you guys utilizing OCTA presently in your practice?
I usually use OCTA for my AMD patients, especially if they're not responding to therapy. And I will use it in my diabetics, similar to the sickle cell, especially young, uncontrolled diabetics with vision not unexplained, that I can't explain otherwise. I'll look at that foveal vascular zone with an OCTA.
I agree. I also use it in AMD patients, especially if I'm injecting one eye and watching closely the other eye, if they have a regular AA or PED. I do want to know if there is CNVM present. Not that I would treat that CNVM, but it would just changes my follow-up interval and how closely I'm watching that eye.
New distortions, and the OCT looks the same.
I'll tell you one of my favorite applications for it is having a patient that may be suspected of having age-related macular degeneration, sort of a mimicker disease like a pattern dystrophy or an acquired vitelliform lesion, and being able to do OCTA on them without subjecting them to a dye test from conventional fluorescein angiography, and being able to tell that patient just with using OCTA that they indeed do not need an injection is a great diagnosis to make, and the patients are usually happy about that, especially if they're fearful of an injection.
I think there's also kind of going along that there's a subset of patients that before we had the availability of OCTA, we were kind of just monitoring because it'd be the stable PED. And especially with these acquired vitelliforms, sometimes they can look like there's some subretinal fluid. And now that OCTA is so easily available and easily obtained, I think being able to kind of reassure ourselves of the diagnosis we've kind of been carrying forward for the past few months or few years can just let us all kind of rest a little easier at night.
Absolutely. I have to say I'm very proud of this group because the Retina Institute, because we were selected as a beta testing site for OCTA angiography way back when, 6, 7, 8 years ago. And then we've been using it all along since then for select patients where it's been very helpful and been sort of a key to some diagnoses. And granted, it doesn't have to be used in every single patient with macular disease. And we've been doing that for a while. And just now it's actually received a J code where just now can we get actually reimbursed for doing this test that we've been doing all along for the benefit of our patients. So that's kind of nice to see.
I think the highest utility of OCT angiography is in chronic central serous with concomitant choroidal neovascular membrane and a CNVM in MACTEL. If you use conventional modalities, meaning structural OCT or fluorescein angiography, you might not get a straight answer in these two conditions. So OCTA will give you the definitive answer. And then in the other more common exudative maculopathies like wet AMD, DME, is just an adjunct to delineate the pathology a little bit better. Now, one thing that has been an interest of mine, and it has been alluded by some of the trials with the second generation anti-VEGF agents, is that perhaps faricimab can lead to a shrinkage of the choroidal neovascular complex. In the past, we've never seen that with any of the other agents. So I'm utilizing OCT angiography in wet AMD patients to actually determine if faricimab leads to a shrinked choroidal neovascular membrane. They did report on this matter in the pivotal trials that led to the approval of faricimab, but it was fairly limited, so we really don't have a lot of data on that.
There's a question from the audience about insurance coverage for OCT and OCT angiography, whether or not insurance would pay for both tests on the same day. The answer is no, it does not.
Looks like we have another question. Helpful if there's heme in the vitreous. If there's any sort of immediate opacity, because we're looking at light reflectance there off the retina, it's going to degrade our view. If I have some sort of hemorrhage in the vitreous, I'll probably get an FA if the view is good enough because I'm able to see through that a little bit better. OCTA may be limited by the shadowing of that hemorrhage to get a good look at the retina.
That's a good point about how OCTA, very helpful, non-invasive, but doesn't entirely supplant conventional fluorescein angiography or indocyanine green angiography. I think those still have a role to play, although I think we're doing them less and less often.
Especially wide-angle fluorescein angiography in diabetics. Right now, there are wide-angle swept source OCTAs that are not heavily utilized. Certain places have them and the acquisition is time consuming. So at this point, I don't think OCT angiography can be superior to a wide-angle fluorescein angiogram for diabetic patients. Once swept source OCTA modalities are more widely spread used and the acquisition time becomes much faster, it might be better in the future, but right now the Optos FA has an advantage.
Well, good, excellent comments, and again, thank you, Dr. Blackerby. So we'll go ahead with our next talk. We're just ahead of schedule by a minute or two, which is fine. Our next speaker is one of our first-year vitreoretinal fellows. It's Dr. Ray Wong, and he's doing an excellent job. He's going to be doing an update on diabetic retinopathy for us. Dr. Wong.
All right, good morning, everyone. Thank you for letting me give this talk. The title of my talk is Updates on Diabetic Retinopathy. I have no financial disclosures. An overview of today, so I'm going to start by talking about the prevalence of diabetic retinopathy, the challenges to treatment, stages of diabetic retinopathy, and treatment approach paradigm. So diabetic retinopathy is the leading cause of blindness in the working age population. The Joslin Diabetes Center Survey was a 10-year observational study of self-reported awareness or presence of diabetic retinopathy in over 26,000 patients with diabetes who underwent retinal imaging during an endocrine visit. What the survey found was that over half of the patients with vision-threatening levels of diabetic retinopathy were actually unaware that they had any eye disease at all. And another finding was that only about 60% of the individuals with diabetes received a recommended annual eye exam. The Wisconsin epidemiologic study for diabetic retinopathy found that the duration from diabetes diagnosis and blood sugar over time affected the onset and progression of diabetic retinopathy. So in type 1 and type 2 diabetics, about a quarter develop retinopathy at 5 years. And then by 15 years, up to 80% in type 1 diabetics will develop retinopathy compared to 60% in type 2 diabetics. This is a systematic review for population-based studies that was published in 2020, and it looked at the global prevalence of diabetic retinopathy and trended it for 2030 and 2045. It included 59 studies, and the projections were made using the International Diabetes Federation estimate, and essentially they assumed a constant prevalence rate for diabetic retinopathy and associated complications. This is a global map showing diabetic retinopathy prevalence and by number in 2020. You can see that by prevalence, diabetic retinopathy in the North America and Caribbean region is quite high and the second highest worldwide with the prevalence of 33.3%. And of those with diabetic retinopathy, 7.8% had vision-threatening levels of diabetic retinopathy, and 4.9% had clinically significant macular edema. And when projecting for 2030 to 2045, we see a continued increase. So from 15.9 million patients in 2020 to approximately 21.1 million patients by 2045 will have diabetic retinopathy. So we see here that diabetic retinopathy is highly prevalent. It's an issue that will continue to grow. So what are the challenges? I think for one thing, it's important to acknowledge that these patients are different from the typical AMD population. Diabetes affects the whole body, so a lot of times these patients have other comorbidities that require medical attention. They're often working age, and it's difficult for them to take time off to come in. A lot of times that means, they don't get a paycheck. Efficacy, we are fortunate that there are so many treatment options now, and our treatments work quite well. But patients still need repeat treatments, and other factors such as A1C affect the severity of their retinopathy. We also know that loss of follow-up can be a challenge in this population as well, and this rate has been reported to be anywhere from 10 to 27%. So this was a recent publication in Ophthalmology Retina that looked at loss of follow-up in patients with diabetic retinopathy. And they defined loss of follow-up as not having a appointment within 12 months from the last treatment. So that's a pretty generous definition. And what they found was that the rate was approximately 10 to 12%, so quite high there. And when it comes to staging diabetic retinopathy, the most commonly used is the ETDRS grading system. There is also a DRSS scale, but the DRSS scale isn't as useful in the day-to-day clinic setting, and it's mostly used for clinical trials to characterize diabetic retinopathy. So here's a photo of a patient with diabetic retinopathy, an Optos photo. What we see is dot blot hemorrhages kind of scattered across all four quadrants. And we get an OCT, and it looks pretty good. And we don't see any signs of diabetic macular edema. And we get an FA, and we see areas of microaneurysm, some non-perfusion in the periphery, but otherwise no signs of any neovascularization. So this is an example of someone who has moderate to moderately severe NPDR. And we're going to focus our discussion on that group. So here's a representation of diabetic retinopathy grading scale using the ETDRS scale and the DRSS score. I want to focus specifically on the management of moderately severe NPDR and severe NPDR because I find it's a little bit more of the gray zone since before that point, you're observing for the onset of DME or progression to PDR. And once you hit PDR, most of us would start to consider doing PRP or intravitreal injections for any signs of NV. And then once you go beyond that, you run into non-clearing vitreous hemorrhage for which we're considering a vitrectomy. The first study I wanted to talk about is the Panorama study. Essentially, the question that they wanted to address is, does treatment of moderate to severe NPDR improve the DRSS score? In other words, can we turn back the clock with intravitreal injections of anti-VEGF? This study was a multi-center study with 402 patients with DRSS scores consistent with moderately severe to severe NPDR. It had 3 treatment arms. The first treatment arm got monthly injections times 3, then Q8 weeks times 1, followed by Q16 weeks. The second treatment arm got monthly injections times 5, Q8 weeks until week 52, and then PRN treatment onward. And then the third treatment arm was a sham group. The main treatment outcome was proportion of the eyes with 2 steps or greater improvements in the DRSS score. This is a graph showing the proportion of eyes with a 2-step or greater improvement in DRSS. And you see a pretty big difference between the sham and the treatment arm. The treatment arm reached, about 60 to 80% of the eyes had a 2-step improvement. This is another graph showing vision-threatening complications. We see that the rate is significantly higher in the sham group at approximately 30% compared to the treatment group, which were less than 10%. This is looking at incidence center involving DME, similar story here, much higher in the sham group compared to the treatment group. So the primary endpoint, which is proportion of eyes with a 2-step or greater improvement in DRSS score from baseline, was met at weeks 24, 52, and 100. At week 100, the treatment group developed significantly less vision-threatening complications in center involving DME compared to the control group. And for this, the FDA approved aflibercept to treat all stages of diabetic retinopathy. So the question is, should we treat moderately to severe NPDR in the absence of DME? We see from this panorama study that even getting 4 injections a year can decrease the chance of developing vision-threatening complications in DME by 3-fold. Traditionally, our treatment has been more reactive for diabetic retinopathy. We treat after we see DME, we treat after we see MV, but this study argues that perhaps we should take more of a proactive, preventative approach. So out of this came the DRCR protocol W, which now has 4 years of follow-up data. These results were published in 2023. And the question it tried to address was, does treatment of moderate to severe NPDR with aflibercept prevent vision loss and vision-threatening complications? It was a multi-center randomized trial of 399 eyes with moderately to severe NPDR without DME. Now we have 4 years of data. It had 2 treatment arms. The treatment arm received monthly injections times 2, 1 Q8 week injection followed by Q16 week injection, and the other group was sham. So we see here data here that supports the panorama study that treatment statistically lowers the incidence of PDR or center involving DME with vision loss. But this is the most important graph from the study, from the Protocol W study, which is that even though the incidence of PDR and DME is statistically lower, the overall vision did not change between the sham and aflibercept group throughout those 4 years. So the DRSS score improved 2 steps or more in 54.3% of eyes in the treated group compared to 28.5% in the sham group. The cumulative incidence for PDR or center involving DME was 33.9% in the aflibercept group compared to 56.9% in the sham group. The mean change in visual acuity from baseline to 4 years was equal between the 2 groups. So while the Protocol W data supports that DRSS score improves if you treat severe NPDR eyes and the incidence of PDR and center involving DME is lower, the mean change in visual acuity through the 4 years was not statistically significant. So one end, you have intravitreal injections, and on the other end, you have incidence of DRSS score, PDR incidence, center involving DME. So how do we balance the treatment, especially when vision is not affected? As eye care providers, we see the consequence of PDR, but to a young patient with severe NPDR, intravitreal injections can be a hard sell, especially when that eye is seeing 20/20. So, if you decide to selectively treat some patients who are at high risk of developing complications of severe NPDR, is there a way to identify these patients? And this was addressed in the post-hoc analysis from the Panorama trial that tried to look to see if certain systematic or ocular characteristics are associated with NPDR worsening. So this was a multivariable analysis looking at baseline systematic and ocular factors indicative of NPDR worsening at week 100 in sham-treated eyes. So this study looked at 638 baseline factors and found 5 factors that were confirmed by multivariable analysis as being significantly associated with vision-threatening complications, center-involving DME, or greater than 2-step DRSS score. These 5 factors included retinal non-perfusion area, fluorescein leakage area, eosinophil count, proteinuria, and central subfoveal thickness. We're probably not going to be ordering eosinophil counts or urinalysis, but since we do often get FAs, especially on new diabetic patients, I think that if we wanted to selectively treat some severe NPDR patients, we can use retinal non-perfusion area and fluorescein leakage area to help make that decision. So in summary, diabetic retinopathy is a leading cause of blindness in working-age adults. The global burden of diabetic retinopathy is expected to remain high. Intravitreal aflibercept for NPDR was associated with improvements in DRSS score, lower rates of vision-threatening complications, and center-involving DME, but had no change in the visual acuity outcomes. Increased FA leakage area and retinal non-perfusion areas are associated with vision-threatening complications of NPDR. Thank you.
Dr. Wong, excellent. Very nice update. Comments from the panel?
Ray, the hardest thing I've found in any treatment in the retina is treating patients that don't think they have a problem. What strategies do you have? This is asymptomatic retinal detachments, anything. What do you think is the best strategy to treat, or how do you convince these patients that they have a problem if you do buy into treating just diabetic retinopathy by itself?
Yeah, that's a good question. So I think having a picture is always helpful, obtaining optos, showing them exactly, the extent of their disease so that they understand. Because like you said, if they don't have DME, if they're seeing 20/20, it's a very hard sell. And I think counseling is a big thing, kind of telling patients, hey, these are your options. If they were proactive and they wanted to do something about it, counseling them about these injections, what that means, and ultimately kind of letting them make the decision is helpful.
I think you hit it right on the head. It's definitely counseling of patients. We get some of these patients who do an injection, they get better. They're like, oh, you cured my DME. I'm 20/20 right now. And then we don't see them again for 9 more months. So letting them know that this isn't curing their diabetes, that we are just helping treat the complications of your diabetes and ongoing care is necessary is critical when you see these patients.
Is anyone treating patients with non-proliferative diabetic retinopathy without DME?
I'm treating only the very high risk patients for conversion to PDR. So for example, one eye has PDR, the other eye has very severe PDR with multiple areas of peripheral non-perfusion that it's just a matter of time when the neovascular membranes will start growing. So yes, these patients I will treat, but we're talking about the very small cohort of patients, selected few cases. Definitely, I'm not treating the way that we're treating in the Panorama trial. So that's the other reason that these treatments haven't been heavily used in NPDR without DME, because there's really no endpoint. What are you going to be doing? Counting the hemorrhages or looking at the DRSS scores? It's not practical to do these things. So, but for these high-risk patients, yes, I will treat them.
I absolutely agree, and that's where the fluorescein angiography is so very helpful. And treatment choice for me is going to be a PRP laser to those areas of non-perfusion that Dr. Augustus mentioned. I've seen a lot of diabetics, especially young diabetics with questionable follow-up, that if you're in my office, I would like to make sure you're treated before you leave because I'm not sure when I will see you back. So definitely CV and PDR is I also treat in certain circumstances. And right now, as we're talking about, we do have a clinical trial going on at the Retina Institute with the DRCR network, the Protocol AF, looking at the oral medicine to slow down progression of NPDR, which we are very excited about because as much as we like injections, if we can offer a patient an oral medication that will slow down the progression of diabetic eye disease, that's something is to celebrate. So we're really excited about to see the results of this study.
Excellent. That's a great segue, Dr. Fromal. During our break, which we will start now for about 10 minutes, there's going to be a video playing if you go grab a cup of coffee, whatever you need to do. But during the break, we'll show some slides that kind of highlight some of the many trials that we're doing here at the Retina Institute, including the one on phenylfibrate that Dr. Fromal mentions. So see you in 10 minutes. Okay, welcome back from the break. So this is the moment you've all been waiting for. This is featuring one of our second-year fellows, Dr. Jake Anderson, who is going to be staying with us this year once he completes his fellowship training at the end of June. So we're very excited he's going to be joining us. He's going to be talking to us today on inherited retinal disease and masqueraders. All right, Dr. Anderson, go for it.
All right. Thank you for the introduction, Dr. Smith. Like he mentioned, my name is Jake Anderson. I'm one of the second-year Retina Fellows, and I'm very excited to be joining the practice this fall, so I look forward to working with you all in the future. I think this talk was strategically placed after the coffee break, so I'm going to try and keep it as engaging as possible, and we're going to talk about inherited retinal disease. I'm going to talk initially just about a general overview of inherited retinal disease. We'll talk about two main inherited retinal diseases and discuss their differentiating factors from masquerading conditions. And then towards the end, we'll touch on some emerging therapies and new treatments that I think make this field very interesting. I have no financial disclosures. So starting off with the definition of inherited retinal disease, this is essentially a genetic mutation that ultimately alters the structure and function of the retina. It affects about 1 in 2,000 people in the general population, and these diseases have a very high visual burden on the patients that they affect. The reason for that is they often manifest early in life, and so these patients have some kind of visual complaint or visual disability for the vast majority of their life. And these have been very frustrating conditions to evaluate and treat as providers, because historically there hasn't been a whole lot of treatments that have been available for these patients. However, as I mentioned before, I think this is a really exciting time in this field, and I think we're kind of at an inflection point in the field of retina where we're starting to see a lot of progress in new clinical trials and new emerging treatments out for inherited retinal disease, and especially with the development of gene therapy treatments. I think there's going to be a lot of new treatments, and there'll be kind of a boom in therapies, and I'm excited to see how that plays out in managing these patients in the future. So when should you suspect an inherited retinal disease? There's a couple factors that can clue you into the fact that a patient may have an IRD. One being, as I mentioned earlier, these are going to be early onset diseases, so typically can manifest in the teens and 20s, but there's variable onset depending on the condition. They typically have bilateral and symmetrical involvement, and they're usually slowly progressive diseases. A couple characteristic features can clue you in to suspect an IRD, such as pisiform fleck material or bone spicule changes. And then obviously a family history can clue you in as well. So a general approach to inherited retinal disease, this classification system is actually referred to as the Iowa classification model, and was developed by Dr. Ed Stone and others at University of Iowa. And I think it's a great way to kind of simplify a complex topic. And so they kind of break inherited retinal disease down based on where the alterations in the retina are happening. So the first category that's the most common is the photoreceptor diseases, which accounts for about 65% of inherited retinal diseases. These include things such as retinitis pigmentosa, cone rod dystrophy, achromatopsia, and others. It affects the photoreceptor layers, including outer plexiform, outer nuclear layer. The second category is macular dystrophies. These affect the RPE and include diseases such as Stargardt's disease and Best disease. The last category is kind of the catch-all category. It's termed the third branch disorders, and these include things that affect the inner retina, such as X-linked retinoschisis, and the choroid, such as choroideremia. So there's a long list of inherited retinal diseases, and it can seem kind of daunting to tackle this subject. However, it's important to note that if you look at the overall prevalence of these conditions, non-syndromic retinitis pigmentosa and autosomal recessive Stargardt's disease accounts for about 50% of all inherited retinal diseases. So the point that I wanted to make is that knowing these two diseases really well can actually help you in evaluating and treating about half of IRD patients that you'll encounter. So for the rest of this talk, I want to touch briefly on both of these two diseases. So we'll talk through the evaluation and some masquerading conditions. And then at the end, we'll touch on some gene therapy treatments. So starting off with non-syndromic retinitis pigmentosa, this is a complex condition where multiple mechanisms are at play that ultimately lead to dysfunction and death of the rod photoreceptors. And while it mainly affects the rod photoreceptors through cell-to-cell communication and apoptosis, it can eventually affect the cone photoreceptors as well. This is what's termed a genetically heterogeneous disease, meaning that there's many different genes that essentially cause the same phenotype. There's been over 80 genes and 3,100 mutations that have been related to non-syndromic retinitis pigmentosa. And there's three main types of inheritance: autosomal recessive, autosomal dominant, and X-linked. X-linked is the least common and has the worst prognosis. And you can see here I've listed the most common genes associated with each one. So as we evaluate patients with retinitis pigmentosa, they most often present with nyctalopia or night blindness, and they can have peripheral visual field loss, which can progress with time. The classic clinical triad is bone spicule changes that occur in the mid and peripheral retina, as well as vascular narrowing and a waxy optic disc pallor, which you can see in this photo on the right-hand side. These patients can also suffer from cystoid macular edema, epiretinal membranes, and PSC cataracts. OCT in retinitis pigmentosa can show thinning of the outer nuclear layer and ellipsoid zone loss. You can see in the arrows in the figure A show that area of thinning outer nuclear layer where it's preserved centrally, and in figure B you can see the preservation of the outer nuclear layer in those peripheral areas. C is demarcating kind of the same area that's showing preservation of the ellipsoid zone, which you lose as you move into the more peripheral retina compared to the normal OCT in figure D. On fundus autofluorescence, the bone spicule changes are going to show up as hypoautofluorescent. However, in the macula, you can get hyperautofluorescent changes due to increased lipofusion buildup and increased metabolic demand in the diseased retina affecting the macula. And this hyperautofluorescent ring can actually constrict over time, as you can see in this figure towards the bottom, which can act as a marker for disease progression. ERG can be a helpful tool in evaluating these patients, and typically shows a depressed A and B wave and delayed dark adaptation. And this occurs along a spectrum. So early in the disease, you can get more mild changes in these responses, whereas you can see here in more advanced RP, you can essentially get non-responsive ERGs. Goldmann visual field testing is often used to monitor progression of the visual field in these patients. And the classic finding is a ring scotoma in the mid-peripheral visual field. And this ultimately will progress as the disease progresses, encompassing the entire peripheral visual field and leaving patients with essentially a central island of vision. So I wanted to go through a couple cases here. This is actually a patient that was referred over to us for a possibility of retinitis pigmentosa. This is fundus image of the right eye, and you can see your attention is immediately drawn to the classic bone spicule changes that we can see with this disease. However, it's fairly isolated to that nasal quadrant. Otherwise, the macula appears relatively normal. This patient of note was maybe in their 60s and didn't have any notable vision changes from their standpoint. On the autofluorescence imagings, we can see hypoautofluorescence within that area of bone spicule changes. And then if we look at the left eye, there's some diffuse mid-peripheral drusen, but no other significant bone spicule changes or macular abnormalities. So there's a couple things that can clue you in this case, that it's not retinitis pigmentosa. Upon further questioning with this patient, he actually revealed that he had a pretty significant trauma to the right eye when he was younger, about 5 years old. He had a traumatic injury with a BB gun. And so traumatic injury, blunt trauma can cause damage to the RPE and can actually manifest with bone spicule changes. And so knowing that can help you in the evaluation know what questions to ask to kind of deduce what's going on. So given that history, the overall asymmetry between the eyes, lack of family history and the patient's age and lack of symptoms were very relevant in this case in trying to figure out what was going on. This is a similar case, actually. This patient was, again, in their 50s. This patient came in with diffuse, or I guess focal RPE changes and bone spicule changes, again, affecting the nasal and more inferior quadrants. Being the good clinicians that we were, we learned from the last case when we asked them about any history of trauma. However, they denied this, and so we're going to have to look for some other answers. And then if we look at the autofluorescence imaging, again, there's some modeled hypoautofluorescence that is correlated to the areas of concern. In the fellow eye, again, there's no changes within the macula and the mid-periphery. However, this patient actually had a chronic retinal detachment, and you may have picked up when you looked at those images that there was some abnormalities of the optic disc, and this patient actually had optic nerve coloboma and some chronic subretinal fluid that created a chronic retinal detachment. And while this is a unique complication of this, the point is that chronic retinal detachment can actually manifest with these RPE changes and bone spicule changes as well. So the point that I'm trying to make with these cases is that bone spicule changes is not always related to RP, especially in asymmetrical cases. And you can see on the OCT, this representative photo showing some subretinal fluid that can clue you in as well. This case is a little bit more difficult. This patient was came into clinic and had some significant vision changes over a few months, and they have this widespread RPE changes and few scattered bone spicule changes, maybe some arteriolar narrowing, which looks pretty typical for retinitis pigmentosa. However, the big clue here is that you can see on these Optos photos the media haze that is actually present in both eyes. It's a little more prominent on the left photo compared to the right photo. And so that's going to be important in evaluating this patient. On the autofluorescence, there's actually some pretty striking images showing this modeled hypoautofluorescence within the periphery. However, there's relative preservation within the macula. So this patient was actually diagnosed with bilateral syphilitic uveitis. And as I was alluding to, the presence of vitritis and media opacity was the big clue in this case. This patient also had subacute symptoms, meaning that it progressed significantly over about a few months, whereas an inherited retinal disease, you would expect a slower progression over years and years. So especially if patients have any inflammation or media opacity, presence of vitritis, you really need to suspect inflammatory and infectious etiologies, which can cause similar findings. The autofluorescence also had the lack of hyperautofluorescence within the macula, which can clue you in as well. So again, this is not a comprehensive list, but these are just a couple things to keep in mind that can mimic retinitis pigmentosa, like we discussed before, trauma, chronic retinal detachment, but it's also important to remember infectious, toxic, inflammatory, and autoimmune etiologies that can also manifest with bone spicule changes. So as far as management for retinitis pigmentosa, Luxturna is actually the only approved FDA gene therapy treatment for currently for retinitis pigmentosa. This was actually approved in 2017, and it is still currently the only FDA-approved treatment in ophthalmology. Interestingly, this actually only treats patients with RPE65 mutations. So this accounts for about 1 to 2% of patients that have retinitis pigmentosa. And so while it's exciting to have some gene therapy treatments, I'm looking forward to in the future getting expanded gene therapy treatments that can treat a broader spectrum of retinitis pigmentosa patients. Outside of this, patients are typically followed annually, and OCT and Goldmann visual field testing can be helpful in monitoring for progression. Historically, we've offered vitamin A supplementation, DHA, and lutein. However, there's some debate on whether or not these supplements are truly effective in this condition. And then the cystoid macular edema that can be present in these patients is typically best managed with carbonic anhydrase inhibitors. So switching gears here and talking about autosomal recessive Stargardt's disease. This disease is a little different from retinitis pigmentosa. There's a wide range of the onset of this disease, but more severe disease tends to progress in younger patients. If you remember from before, this falls under the macular disease category, and so it typically affects the RPE and results in central vision loss and can, in later stages, result in macular atrophy. This is kind of opposite of retinitis pigmentosa, in fact, that there's typically just one gene that's involved with Stargardt's disease. And so it's what we call a phenotypically heterogeneous disease, meaning that there's only one gene, but it causes a multitude of phenotypes, which can make it more difficult to diagnose. Given the fact that only one gene is typically involved, the ABCA4 gene, it's really important for us to understand what that gene does. And without getting too into the details, it's essentially responsible for clearing toxic byproducts of the visual cycle. So it flips NRPE from the inner to the outer leaflets of the disc membranes during the visual cycle, and the inability to do this at a normal rate actually results in the accumulation of A2E and toxic byproducts such as lipofuscin. And so depending on how well this gene is working, it can lead to a different range of phenotypes. So if the gene is working overall fairly well and there's only mild dysfunction, the retina is able to still rid the photoreceptors of A2E, and there's preservation of the photoreceptors, and it mainly just accumulates in the RPE. And this can manifest as more mild phenotypes such as pattern dystrophy. And then as the gene mutations are worse and you get more moderate phenotypes such as cone dystrophy, and it starts to affect the cones preferentially first because they turn over more slowly than the rods. And so you'll get preferential injury to the cones and cone dystrophy phenotypes. More severe phenotypes can affect both the cone and rod photoreceptors, can actually mimic conditions such as retinitis pigmentosa. And again, here, this is just a schematic showing the different range of phenotypes that you can get with autosomal recessive Stargardt's disease, more mild on the left, and then kind of the more RP phenotypes on the right. So I want to talk a little bit kind of more about classic Stargardt's disease and how this can manifest. So on fundus imaging, the classic appearance for Stargardt's disease is pisiform fleck material, which you can see very apparent in this image with the flecks scattered throughout the macula. And then in the foveal region, you can get this beaten brawn appearance, which is secondary to some pigmentary and RPE changes. And as the disease progresses, this can eventually lead to macular atrophy. On autofluorescence, it's important to note that with Stargardt's disease, you can often get peripapillary sparing, which could be a very helpful tool to look at in differentiating this from other diseases such as age-related macular degeneration, where you don't have this preservation of the peripapillary area. There's a couple theories as to why this happens, but in general, it's thought that there's lower cone photoreceptor density around the peripapillary region and less metabolic demand. And so this is affected later in the disease in Stargardt's, and so it's typically spared. The fleck material is usually hyper-autofluorescent, and areas of atrophy manifest as hypoautofluorescence. Fluorescein angiography will show a dark choroid in up to 80% of patients, and this is pathognomonic for Stargardt's disease. This phenomena happens because of lipofuscin buildup within the RPE that blocks the choroidal fluorescence. OCT can show a wide range of abnormalities, but in general, there is most often thinning of the outer retinal layers along with ellipsoid zone disruption, and the fleck material that we discussed earlier typically manifests as hyperreflective subretinal deposits. So let's go through a couple cases that can mimic Stargardt's disease. This patient presented in their 50s with some overall mild vision changes. They were about 20/25 in both eyes. However, if you look closely at the macula, you can see some subtle pigmentary changes and RPE changes. And so sometimes additional imaging can be very helpful in these patients, especially autofluorescence. And if you look at the autofluorescence images, there's actually some pretty striking features for a reticular pattern in both eyes. And you can also note that there's no pisiform fleck material as well. And so this patient was actually diagnosed with reticular pattern dystrophy rather than Stargardt's disease. And a couple of things, as I mentioned before, can clue you in: the absence of the pisiform flex, later disease onset and overall preserved vision in reticular pattern dystrophy compared to Stargardt's disease. And then if you were to do an FA on this patient, you would see absence of a dark choroid with the pattern dystrophy. This is a representative case of a patient. This patient would be presenting often later onset in their 70s and 80s with this diffuse macular atrophy. But I wanted to illustrate kind of the point that I made before, where in this patient, there's actually involvement of the peripapillary area. You can see that area in the fundus photo on the left and the fluorescein angiography on the right really highlights the diffuse nature of that atrophy that's kind of encompassing all around the optic nerve. And so this patient was diagnosed with dry AMD with geographic atrophy. And you can see on the figure on the right, these, depending on when the patient presents, these two entities can be fairly similar. So the left-hand column is a patient with AMD, and the right-hand column is a patient with late onset Stargardt's disease. And while they both can have atrophy, the presence of the pisiform flex that, especially with autofluorescence imaging, can be very helpful in differentiating these diseases. You also can, in general, see faster progression with geographic atrophy and AMD compared to Stargardt's disease, and then family history can clue you in as well. Last case I wanted to discuss is a little more subtle. This patient came in with slow progressive changes, which could be indicative of inherited retinal disease. They were a little bit older as well. However, if you look closely at the fundus photos, you can see some very mild hypopigmentation around the foveal region. And then you can see it's highlighted a little bit better on the autofluorescence imaging as a hyperautofluorescent ring. It actually looks a little bit like retinitis pigmentosa. However, it looks indicative of the bullseye maculopathy morphology of ABCA4 mutations as well. This is much more apparent on the OCT. You can see this parafoveal thinning, loss of the outer nuclear layer, and ellipsoid zone with preservation at the fovea. However, while the differential is very wide for bullseye maculopathy, the thing that you don't want to miss is toxicity, which can be intervened on. And so this patient actually had hydroxychloroquine toxicity, and they had a 20-year history of hydroxychloroquine or Plaquenil use. And so this was really important in the management of this patient, taking a thorough history, asking about these medications, and again, differentiating it from autosomal recessive Stargardt's disease. You can see the juxtaposition of these two patients. On the left is the hydroxychloroquine toxicity, and on the right, the bullseye maculopathy phenotype of Stargardt's disease can manifest similarly, but the pisiform flex are the key differentiating things, along with the onset and a good clinical history can clue you in as well. So again, not a comprehensive list, but just a couple things for you all to think of when you're evaluating Stargardt's disease. Things that can mimic this condition are pattern dystrophy, age-related macular degeneration, bullseye maculopathy, especially toxic conditions, and then central serous chorioretinopathy. The more chronic form can manifest with outer retinal RPE disruption. So unfortunately for Stargardt's disease, there's currently no FDA-approved treatments. However, there's several therapies that are under investigation currently that have shown a lot of promise, and so I think we're definitely going to have treatments in the future for this disease. A couple things that are being investigated right now: oral medications such as metformin and gildaretinol, which is a modified form of vitamin A, have shown some promise, and then gene therapy treatments I think are going to be at the forefront of managing this disease, and there's some ongoing clinical trials, including one that we're involved with at the Retina Institute right now, or will be in the coming months. I think is really exciting. Gene panel testing can be very beneficial for these patients in the evaluation and management. There's several different companies that offer this, and is usually billed through insurance, or there's some that are actually free to patients still. And it can help in suspicious cases, especially with patients with either family planning. There's also resources through some of these companies for genetic counseling and can also determine eligibility for clinical trials. So I wanted to put a plug here for the Retina Institute, as we're going to get involved with a ongoing trial for Stargardt's disease. And we're really excited about this. It's a study through Ocugen, and it's a subretinal gene therapy that's administered in the OR. And so this is a one-time treatment, and the phase 1 results have showed really promising results with 52% slower lesion growth rate at 6 months and a 10% ETDRS improvement in visual acuity at 6 months, which was clinically significant. It'll be really nice to finally offer some treatments to these patients. So in conclusion, just to recap, there's many different inherited retinal diseases, but it's important to remember that non-syndromic retinitis pigmentosa and autosomal recessive Stargardt's disease comprise over half of inherited retinal diseases. IRDs typically present symmetrically with early disease onset and are slowly progressive, and a positive family history can clue you in as well. There's several different things, including pertinent clinical history and key exam features, that can help distinguish inherited retinal diseases from masquerading conditions. And like I mentioned earlier, I think inherited retinal disease, this is a really untapped potential in the field of retina and ophthalmology in terms of treatments. And I think we're going to see a lot of emerging therapies coming up with the development of gene therapies. So I want to thank you all for your attention, and I hope this helps you with your evaluation and management of patients with inherited retinal disease. And I'm looking forward to being part of the St. Louis ophthalmology community.
Thank you, Jake. That was wonderful. That's a hard topic to digest within a half hour. So thank you for that. There was a question from the attendees of what's the ideal patient that might qualify for enrollment in the upcoming phase 2/3 Ocugen trial?
Yeah, that's a good question. So part of it is going to depend on whether they qualify based on their genetic testing. But I think if they are symptomatic and are presenting, especially at a younger age, I think the potential with these gene therapy trials, it doesn't necessarily reverse the disease that's already happened. So if someone has significant macular atrophy and is more later stages in the disease, I don't think they're necessarily the best candidate. But if they're actually earlier in the disease onset, I think that's where the potential really lies for what patients may benefit the most.
Yeah. Good. My understanding is they only need one genetic mutation in ABCA4. So as long as they have a phenotype that's consistent with Stargardt. So that certainly opens the door for a lot of potential candidates. I know you've done a lot of work over the years since beginning your fellowship on compiling our patients with inherited retinal disease through genetic testing. Can you share any insights about what you've learned from that?
Yeah, kind of like I was talking about before, I know you and I and a couple others at the Retina Institute have worked on some papers discussing kind of what do we do with these gene panel testing results that we get, because it can be kind of confusing, and the confounding factor is that there's a lot of people in the general population that actually have ABCA4 mutations. There's a high rate of that. And so the question always becomes, if you get a gene panel back and it has an ABCA4 mutation, how often does this actually correlate to disease? And we found that the gene panel testing is actually very sensitive. And so typically you have to have 2 ABCA4 mutations to manifest disease. And the other thing that we found looking at this that just corresponds to what I was talking about earlier is that the Stargardt's disease has a really wide range of phenotypes. So we can get patients that present with more of a pattern dystrophy, more of a bullseye maculopathy, really a significant central atrophy. And so especially when the disease is symmetrical and bilateral, I think it's important to keep IRD or Stargardt's disease at the forefront of your mind in evaluating these patients.
Any other comments? Okay. Well, nice work. Very good. Thank you. We're so excited that you are joining us. Okay, well, our next session is another spotlight session. So I'm going to pull up my screen here. And this is kind of revisiting another topic that Dr. Papakostas spoke about at this conference a few years ago on the topic of anti-complement therapy for geographic atrophy. So now that we're a couple of years into post-marketing for these drugs, I thought it would be a good idea for us to kind of return to this and discuss it again. And as we know, geographic atrophy basically a complete loss of the retinal pigment epithelium with attenuation of the overlying neurosensory retina. Remember that just in case you need to take a quiz later. And here's a case just to kind of set up the conversation again, a patient again with essentially monocular status. Here's their right eye that's severely limited by a fibrotic scar. And then in their left eye, we'll show another video, which spans about 4 years or so, showing this geographic atrophy, which, boy, when you speed these things up, it's very scary to see how close this is coming to the central vision, even though their central vision may very well be 20/20, 20/25 at this point. So this is from a paper by Dr. Dimitrios Vavas and Dr. Richard Spade. And I just want to recognize the fact that Dr. Papakostas, along with Dr. Blinder, are the moderators for our upcoming Midwestern Ophthalmological Symposium this September. And Dr. Vavas has actually agreed to be the guest speaker for that event, so don't miss it. Anyway, this is from his paper, and they're just highlighting the idea or the assumption that we have that autofluorescence basically shows death of retinal pigment epithelial cells, and then the surrounding hyper-AF suggests that there's some sick RPE, and that perhaps we should or maybe we shouldn't do whatever we can at all costs to preserve that. And that's at least the assumption. So we now have 2 anti-complement therapies available that have been FDA approved. Pegcetacoplan and avacincaptad have been shown in various phases of clinical trials to be of some benefit. And I'll leave it at that. We're questioning, is it beneficial enough to outweigh the risk of these treatments? Just a quick case here again, October 2021, you see a patient with right eye atrophy involving the fovea. Left eye is foveal threatening. And going back to Dr. Blackerby's talk on the value of OCT angiography, this kind of highlights this. This patient has this double layer sun, pigment epithelial detachments, overlying cyst, and OCTA shows the atrophy of bearing of the RPE capillaris, or bearing of the capillaris because of the RPE atrophy. And then when you segment this further, they actually have a choroidal vascular membrane. So the question becomes, is the choroidal vascular membrane protective in some of these patients? And should we be incorporating that into when we select these patients? But let's just back up just a moment. Let me ask the panel, what do you think about anti-complement therapy?
I'm still not ready for it based on the data that we have. It is not a benign treatment. It is a very intensive treatment regimen if you want to hit these therapeutic endpoints that are suggested with these studies. And we know of some significant safety factors that are also present. So we have such a robust clinical trial department. I'm more excited about the opportunities that some of our clinical trials have to offer for our patients that have reduced the treatment burden associated with these type of treatments. So I'd much rather go that route than the complement inhibitor. That being said, if a patient comes in and is specifically asking for it and has received the information, and they still elect to proceed, I will administer that treatment, but I do have a very thorough, informed consent about what my expectations are with this.
I think the efficacy is probably overinflated because the studies are looking at the anatomic surrogate marker that doesn't translate to anything functional. I'm going to give, the group a different example. Let's say you have a treatment that works for lung cancer and you get radiographic evidence that the lung nodules, don't grow as fast, but the patients die at the same rate compared to placebo, or they develop metastasis compared to placebo. How would you think that this treatment would be, accepted by the medical community? I don't think many people would use it, right? So here we take this anatomic surrogate and we extrapolate and we say, well, it has to work functionally, but it hasn't been shown on the studies. And the studies, were fairly long. I mean, 2 years is enough time to see something, but they weren't able to see any signal on the vision or even other elements of the visual function like microperimetry, contrast sensitivity, dark adaptation, reading speed, and so on and so forth. So the argument that the companies are making that, well, you're going to end up seeing an effect after 5 years of treatment or 6 years of treatment, it's more of a speculative argument, in my opinion, not a factual one. And also this compounded effect, as they call it, you're going to have a compounded effect of complications too. And the complications, tend to be quite serious if you get them. There is a rate of occlusive vasculitis with Syfovre, lower rate with ACP, but it's been reported. There's a rate of ION, and of course the other big problem is the rate of conversion to wet AMD. So all these things taken together make the treatments quite controversial, in my opinion. I'll give the panel another fact. These treatments were not approved in the European Union. The Syfovre was rejected twice, and ACP, Zymura, they basically withdrew their application. In the United States, is the only country in the world that, we can do these treatments. I think Australia is the other one too. The adoption has been quite low. So on the commercial side, these treatments haven't worked the way the companies thought they would work. So all these things taken together make me think about it twice. And then when you talk to the patients and when you tell them what these treatments entail, essentially injections in perpetuity without any visual improvement, without any prevention of visual deterioration, I should say, not visual improvement, without any prevention of visual deterioration, I would say all the patients, they say we're not going to do it.
Yeah. Just a quick kind of comment about that, just to highlight what you were saying. It certainly does not improve the vision. And for you quiz takers out there, it does not reverse the damage that's already been caused by geographic atrophy. Dr. Papakazis, I was wondering if you could comment, going back to your talk a few years ago, which you expertly reviewed all this. Talk about what the difference is between the results from the earlier phase trials to the phase 3 trials with regards to the dropout rate of some of these patients who were candidates in the trial.
Yeah, the dropout rate is more of a big issue in the Syfovre trials. So in the phase 2, in the FILLY trial, there was about 41% of dropout rate in the every month arm. And then when you look at the Derby and Oaks, which are the phase 3 trials, the dropout rate was about 25%. So these are pretty significant dropout rates for a trial like this. And what they did is they essentially, kept the patients that dropped out in their analysis, and they came up with a mathematical model that essentially assumes missing values at random. So they kept everybody in. So instead of saying, okay, 40% of the people dropped out, we're going to look at the outcomes on the rest 60% that finished all the assessments for the trial. That was not the case. They included everybody, and they came up with a model that was basically putting in missing values. So that carries a lot of risk. And this actually played out in the phase 3. One of the trials actually did not show any difference, one of the two trials. So the results, I believe, is a mixed bag. Now, when you look at the Zymura trials, there was a dropout in the phase 2. The dropout in the phase 3 was much smaller. The effect was smaller than the Syfovre trials. And the company started to coming up with a post hoc analysis to see, okay, we didn't really see a visual, benefit overall, but what if we look at patients that experience a significant visual reduction? And they basically said, what's a significant visual reduction? Vision loss greater than 15 letters, 3 lines. What happens with these patients? How many patients do you have in each arm? They showed there was a difference at year 1. They started with 250 patients per arm, and they found out that, at year 1, 15 or 10 patients in the treatment arm experienced severe vision loss compared to 25 in the control arm. So they said, well, there is a significant reduction of this possibility of, severe visual loss at 1 year. But if you look at the numbers are so small to make any meaningful statistical comparisons. And at year 2, the effect that they saw at year 1 was not present there. So even this argument that perhaps it will prevent severe vision loss, it does not hold true at year 2.
Is there a subset of patients, and maybe clinically there is, but there's been this notion that's been floated in the past about genetic risk factors for progression of AMD. And can you comment on that notion that perhaps genetic risk may equate or not equate to geographic atrophy?
Yes, there are genetic risk factors. That's why this whole thing with the complement started, because when we unraveled the genetics of AMD 20 years ago, we found out that certain SNPs in complement factor H conferred a higher odds ratio to develop geographic atrophy. Now, other studies have refuted this data, so actually to look into the complement molecules that are under investigation here, there is not a single study that has conferred susceptibility or protection in terms of C5, which is the target of Zymura. And C3, you have certain studies that say it can be protective and certain studies that say it can go the other way. So it's really hard to tell. The problem is when you take genetic data and you go straight to human trials, there's a high risk of failure. The big issue here, there's no good animal model of geographic atrophy to test all these compounds in the lab and then proceed to a human trial. Anti-VEGF molecules were first tested in a human model of neovascularization. There were multiple different, in an animal model, of retinal neovascularization, NCMVM. So when it showed efficacy there, then proceeded to human trials. Here we go straight from genetics to human trials, and I think that's the problem we're seeing these mixed results.
Dr. Deng, you mentioned the clinical trials that are coming out that you were excited about. I happen to agree with you. We're kind of in this, I wouldn't say, maybe not the right word is difficult situation, but because we have these FDA-approved anti-complement treatments, we're kind of now forced to use them as a comparator. Do you or anybody else on the panel have any comments about that?
Well, it is it's interesting to me that we are still being approached with geographic atrophy trials that have placebo as their control arm, which goes to show that through extensive IRB review and human safety and protocol design, that is not considered necessary to be standard of care. At minimum, anytime we do clinical trials, we should not deny patients efficacious treatment. Now, we are starting to also see clinical trials that are comparing against these anti-complement inhibitor injections. They are coming in. And as we look at those, I think that is a worthwhile scientific endeavor because there still is a lot of question marks out there. And the only way we're going to further clarify the role of these medications is through further study. And I actually like the opportunity to say, let's try 2 agents against each other, one FDA approved and one experimental, rather than saying, let's do additional studies on these existing agents that have FDA approval and post-approval studies compared to placebo and natural history. So I feel like more information is always welcome. And the other thing I am always reassured about, we always strive for safety with our patients with any treatment, but clinical trials really take it to the next degree, where we have opportunities to get much more diagnostics and assessments on these patients to verify that they are not having any adverse events.
Thank you. Okay.
Interesting.
Great. Oh, go ahead.
Interesting point also to bring up. We talked a lot about efficacy of these therapies. How do you counsel your patients about risk of conversion to wet AMD? So you have patients who have never been wet, and then we know that from the real world data that and the clinical trials that there's a significant percentage of the eyes treated with anti-complement therapy does convert. So that's an important conversation to have with patients because the clinical trial data that we have does not include the patient that's treated with 2 agents. So how do you approach that in discussion with your patients?
I personally definitely discuss that. I find that when I mention the possibility that they might not, that they might actually get another or need another injection for a complication of the injection that we're doing with questionable benefit for geographic atrophy, the response is lackluster. They don't seem to be very motivated to do it. And I think it goes back to your comment, Dr. Fromall, that you made earlier about the OCT angiography. I mean, I think this is a great application for selecting out patients for potential anti-complement therapy, in that we should be doing OCT angiography to rule out non-exudative choroidal vascular membrane so that we don't unmask it.
It is a problem, the choroidal neovascular membrane in these patients, the conversion to wet AMD, because if you look at the studies, the patients that converted to wet AMD, they actually lost more vision compared to the control arm. And the rate of conversion in natural history is about 1%, so it's really low compared to the around 10% that we're seeing with all these treatments. The other problem, which is more of a logistical issue, is you're essentially committing these patients that wouldn't be getting injections before now to 2 different sets of injections. So how do you manage reimbursement? How do you manage treatment burden? I mean, there are so many things that come into play that make, treating these patients quite challenging.
Absolutely. Speaking of treatment of wet AMD, we're going to go on to our next talk by Dr. Fromall. She's going to be talking about wet AMD treatment. Thank you, Dr. Fromall.
Thank you very much for this introduction. And as I'm pulling it up, I know we are 3 hours into our lecture, so please feel free to stretch us as eye care providers. We have lots of issues with our backs and necks, so just do a good quick stretch while I'm getting this started. Okay. There we go. All right. Thank you again. So I'll be talking about diagnosis and management of wet macular degeneration. A nice segue from the dry that we discussed earlier. And I do want to thank my partners, fellows, and the ophthalmological community for welcoming me to St. Louis. I've been here a little over 6 months, and it's been a pleasure of taking care of your patients and serving our community. So thank you very much. So let's dive into the discussion. Have no relevant financial disclosures to discuss. So the goal of this presentation would be to review pathogenesis of neovascular degeneration. We'll look at the timeline of AMD therapy discoveries. We'll review some current management options. Then I'll briefly just highlight some clinical trials offered at the Retina Institute for Management of Neovascular AMD. So let's dive in. So we have a case of 87-year-old female who calls in with a sudden loss of vision in her right eye. She does have history of dry macular degeneration. And she's been appropriately counseled by her optometrist about tobacco avoidance, about using the AREDS vitamins, protecting her eyes from sunlight with head and eyeglasses. And she tells you that she checked the grid that you've given her earlier this morning, and then she's seeing significant vision loss. So you don't delay and bring her in for treatment for evaluation immediately. So in presentation, her visual acuity in the right eye is hand motion. So she was 20/20 previously, and you are very worried. Her fellow eye is 20/70 from the dry AMD from geographic atrophy in this eye. She has normal pressures, and there's no afferent relative pupillary defect. So let's take a look at her fundus. So here we see a clear media, normal nerve, normal blood vessels, and our attention immediately drawn to the macular. We do see signs of AMD, so she has scattered drusen, and we see blood. Where is this blood located? So to investigate that, we can follow one of the blood vessels, and we can see that blood vessels coursing on top of the hemorrhage, which tells us the hemorrhage is deep to the retina. And if we're taking a look at the OCT, we first identify the RPE-Brooks membrane complex, and that's in healthy eyes presents a single unit. And as we draw that line, we see that she has large pigment epithelial detachment, and then some subretinal hyperreflective material, which represents blood. And we know that this causes irreversible photoreceptor damage. And not a surprise here, she did convert to wet AMD. So let's talk about AMD pathogenesis. So the first schematic shows the light entering the eye via corneal, lens, vitreous body, and then hitting the retina, and photoreceptors, which are represented in green. The photoreceptors are very metabolically active. As we know, they receive their nutrients and oxygen from the underlying choroid, and then metabolic waste is discarded with the aid of RPE pump through the Brooks membrane back to the choroidal circulation. With age, Brooks membrane undergoes changes, and this transport across the RPE to the photoreceptors is impaired. With additional AMD risk factors like ultraviolet damage, genetic risk factors, it leads to the inflammation and oxidative stress and complement activation and drusen formation, which are represented as the bumps between the RPE and Brooks membrane. And in later stages, we see progression to geographic atrophy, the defined area of RPE cell loss, and as well as pathologic angiogenesis. So there's a choroidal neovascular membrane formed underneath the retina, and we see the blood in the fundus photograph. So what are our current treatment options? Let's first take a quick peek at the development of AMD therapies. So angiogenesis was actually described centuries ago by John Hunter, but it took 2 centuries for the hypothesis of angiogenesis hypothesis to come to fruition. Then later, about a decade later, the first VEGF molecule was cloned, and throughout this time, the only treatment available for macular degeneration was lasers, PDT, and surgery for submacular hemorrhages. But in 2024, the first anti-VEGF became available, and there was also off-label use of bevacizumab for AMD. After that, we have a snowballing effect with multiple anti-VEGF agents that came into the treatment scene, revolutionizing the therapy for AMD. So what's our current landscape right now? So these are the 4 anti-VEGF agents that are most commonly used for treatment of AMD. So we already mentioned bevacizumab, which is an off-label use, and it's full antibody that targets all forms, isoforms of VEGF-A. And then ranibizumab, which is the antibody fragment, and aflibercept, which is a fusion protein or VEGF trap. And most recently faricimab, which is a bispecific antibody that has activity against VEGF-A as well as Ang2. And then aflibercept 8 milligrams that recently been approved, and faricimab, as I mentioned, these 2 provide a longer acting strategies for management of AMD. So with so many medications available, why do we need more? And that's let's take a look at the disease burden. So currently there are over 196 million people affected by macular degeneration worldwide, and this number is projected to increase to 288 by 2040. It is most common cause of irreversible blindness in this age group. And in US, 9 million people suffer with AMD, and this number is projected to increase to 18 million by 2050. And although not all patients develop wet AMD, it is responsible for more severe vision loss. So we definitely need therapies that work better, last longer, and decrease treatment burden. So let's take a brief look what's in a pipeline. So now we will switch gears and talk a little bit about clinical trials. So these medications are on the way to seek FDA approval, and they involve intravitreal injection, intravitreal implants, port delivery system, gene therapy, and home OCT. And they are all available at your neighborhood Retina Institute. So let's dive in. The first two studies we will look at will highlight the use of a novel target, a tyrosine kinase inhibitor, which also blocks VEGF receptors, but a different side. So the first study we'll look at is Lugano study, which is phase 3 multicenter prospective randomized control trial that's looking at the molecule EYP-1901, a tyrosine kinase inhibitor for treatment of AMD as compared to aflibercept. The drug is vorolanib, and it's a tyrosine kinase inhibitor, a selective kinase inhibitor. And it's delivered via intravitreal insert, which is bioerodible and offers the sustained release of medications for at least 6 months. So it demonstrated favorable safety data through the previous clinical trials, phase 2 clinical trials. It is immediately bioavailable and measured in target tissue within hours, and it provides sustained release for at least 6 months. So the next study we'll take a look at is SOL-R. It's also phase 3 multicenter double-masked randomized clinical control trial, and it's also looking at the tyrosine kinase inhibitor, axitinib. And this medicine is also delivered via intravitreal injection, and the medicine is available through the hydrogel implant, and it provides continuous, consistent delivery of up to 12 months. And this particular study has 3 different arms. All arms receive VEGF loading, and then they're randomized to either the target medicine that will be administered every 6 months, or aflibercept 2 or 8 milligrams. And the primary endpoint will be assessed at 56 weeks, and it will be the change in best corrected visual acuity from the baseline. So now let's switch gears and talk about a surgical trial. So this trial is to investigate the tolerability and efficacy of Dutafab administered via intravitreal injections via port delivery implant. So port delivery implant is a small refillable device, and it's meant for permanent surgical implantation within the sclera, as seen as this top photograph here, an external photograph. And it allows for passive diffusion of the drug into the vitreous cavity. And we see this implant through the pupil here in the bottom picture. So what is a Dutafab? The Dutafab is a bispecific molecule that targets 2 signaling pathways. So it targets VEGF-A as well as Ang2. So the next treatment the next trial I want to highlight is the gene therapy trial. So it wouldn't be wonderful to turn off once and for all the pathologic angiogenesis. So this is where the gene therapy comes in. So this trial is a phase 2b/3 study of ABBV RGX-314 gene therapy administered via subretinal injection. So the gene that encodes monoclonal antibody to anti-VEGF is packaged within a viral vector, and then during vitrectomy, it's delivered subretinally. And it holds the key promise of one and done treatment to eliminate the need for frequent injection and to kind of teach the eye to produce its own anti-VEGF. Another unmet need in AMD treatment paradigm is finding out optimal timing of treatment and the number of injections that needed to achieve the best visual acuity and disease control for each patient. As we know, that treatment of AMD is associated with considerable treatment burden and cost, not only to the patient, but to the caretakers who are taking the time off to bring the patient to the appointments, and as well as healthcare system, not to mention the side effects, although very rare, but can be very serious associated with intravitreal injections. So the standard and most commonly utilized therapy treatment kind of strategy for neovascular AMD is a treat and extend method. We deliver intravitreal injection on a monthly basis to our patients until we achieve the disease control, and then we slowly extend the time between the treatments, trying to find a perfect interval between the injections for the patient that allows for good disease control but prevents disease activation. So if we want to find out how often does this particular patient in front of you requires injections, that's where the DRCR protocol AO comes in, and it is a home OCT guided treatment versus treat and extend method for management of neovascular AMD. The home OCT is a small device that is sent directly to patients' home, and they're able to obtain daily scan monitoring the disease activity at home. It's technician free. They can take the scans themselves, and it takes just a very short amount of time to obtain the scan. So let's take a look at the study protocol. It is a multi-center randomized clinical trial. It will enroll 600 eyes from 80 different sites, and the inclusion criteria include patients with AMD that are 50 years old or greater, and then they have confirmed a CNVM lesion. And they are then randomized to the standard treat and extend protocol with faricimab or the home-guided OCT treatment. So here's an example of from DRCR how this will work. So patient acquires daily scans, and then AI algorithm that will detect fluid and send this and plot this information. And when the threshold level of the fluid is reached, the site, the clinical trial site will receive a notification to bring the patient in for an exam. So hopefully this will provide a personalized treatment approach, which is the future for AMD management. So let's go back to our patient. So here she is with this massive hemorrhage and hand motion vision. What do we do? So our treatment goals is to clear the blood away from the macula and to prevent further bleeding. So our treatment option, as we mentioned, we can do an anti-VEGF injection. It is effective. We know it is effective. It is least invasive. It directly targets CNVM. Or we can take the patient to surgery, as was previously shown during this lecture. So this will require, sometimes could be in combination with subretinal TPA administration, and is also very effective. That does come with some complications, cataract, a loss of vitreous reservoir, and other potential complications associated with surgeries. Or there's a third approach. We can administer anti-VEGF and perform a pneumatic displacement. So pneumatic displacement involves a placement of expansile gas bubble inside of the eye, and it's mechanically displaces the hemorrhage. It's minimally invasive. It is performed in the office, and perhaps it will allow faster clearance than anti-VEGF alone. So what does the data say? And I know we looked at a couple studies already today, but the jury is still out. Looks like both methods, the vitrectomy with anti-VEGF and subretinal TPA and the pneumatic displacement, work well. And this really comes into the patient in front of you and their individual presentation. So how long has the hemorrhage have been present, the size and the thickness of the hemorrhage, location of the hemorrhage. So if you have a lot of hemorrhage in superior macular, but none in the fovea, you definitely don't want to displace it into the central vision. Is there sub-RPE hemorrhage present? Because that will not be displaced with the bubble. Is the patient able to position? What's their visual potential to start us, and as well as the fellow eye status? So when we looked at our patient, she was recently symptomatic. She was very motivated to do everything we can to improve her vision. And she was relatively monocular, with her fellow eye being 20/70 due to GA. So she opt in for the pneumatic displacement in the office procedure. So she received intravitreal aflibercept 2 milligrams and then 0.3 cc's of 100% C3F8 with intravitreal tissue plasminogen activator. So let's take a look how she did. So this is her in presentation. Her visual acuity was 20 head motion. This is her 1 week later after positioning. So we still see the gas bubble here in superior macular, and OCT shows improvement of this hemorrhage. We still see the large PED. Her vision here is 21/25, and this is her 3 weeks later. And we see that hemorrhage is completely cleared, the gas is no longer visible, and her vision is 20/60. 3 months later, her visual acuity improved to 20/25. So we talked about a lot of things. We talked about pathogenesis of AMD that involves abnormal growth of blood vessels or pathologic angiogenesis that leads to exudation, hemorrhage, fibrosis, and vision loss. We talked about the timeline of AMD therapy discoveries and reviewed current management options. We highlighted some clinical trials that are offered the Retina Institute, which include, for the test takers, gene therapy, tyrosine kinase inhibitor, port delivery system, and home OCT. We discussed that submacular hemorrhage is associated with poor prognosis if left untreated, and that anti-VEGF is crucial in management of submacular hemorrhage. And we touched upon that pneumatic displacement with anti-VEGF may allow for more rapid improvement in visual in select patients. So thank you very much for your attention, and I'll take any questions. Thanks.
Do you envision a day where we might be injecting or have a medication that's basically a cocktail of substances that decrease choroidal vascular membranes just the right amount? Because choroidal vascular membranes are actually a healing response for the eye. So we don't want to like make it completely evaporate. We do know it's kind of protective against geographic atrophy. And at the same time, might we give something that decreases the atrophy? Of course, what we would really want is a cure. What are your thoughts?
Yes, definitely. I mean, that would be a magic bullet, right? I think we're still a little bit ways off from that, but I do think it's not impossible to have that in the future. Angiogenesis is necessary, and we want to have a healthy eyes that are able to face mount response to stressors, oxidative stressors, and finding that right would it would be a key, but I think we still have a bit of work to do on that.
Yeah. There's a great question from one of the attendees about what do we personally do or take to try and keep our own eyes healthy?
Good, healthy diet, well-balanced diet, protection from sunlight with good polarized sunglasses, and lots of carrots and omega-3s.
And don't
That's
smoke.
my anecdotal evidence.
I like it. No smoking, right?
Yes, no smoking. That's the main one.
That's a wonderful result you got with just injecting the bubble in the office and aflibercept 2 milligrams. I know a lot of times we will, the patient had a small little pigment epithelial detachment, but it was just temporal to the fovea. A lot of times when it comes up as far as like a topic in conferences over the last couple of decades, ever since the era of anti-VEGF. The thought has been, well, if there's sub-RPE involvement, then it doesn't make sense to do a pneumatic. I've actually never really bought into that. I always thought maybe still some gets into the sub-RPE and breaks it up a little bit to make it maybe resorb faster. Do you personally, or does anybody else see pigment epithelial detachments as a contraindication to clearance with TPA?
I think location is a key. So if it involving the foveal center, it's a different discussion. And maybe I would opt for just anti-VEGF alone and maybe one of the older generations. But that's just my personal opinion from anecdotal knowledge.
Mhm. Anyone else on the panel have comments or questions?
I think there are a few questions that came in. Yeah.
Yeah, go ahead. There's a couple questions on from the audience. We ask, how often are we treating submacular hemorrhages with treatments other than anti-VEGF alone? I think in general it's fairly uncommon. I fairly rarely see a large hemorrhage, and there's so many other variables to taking patients to the OR. As we talk about the large PEDs, and particularly in the OR, and injecting subretinal TPA and the risk of and injuring the PED. Those are more. So I think it's actually fairly rare. There's another question, will that patient need continuous injections? I would say yes. Once they've shown a big bleed, I think we talked about that a little bit earlier, once they've shown a big bleeding episode, they don't really get a chance to do it again.
Submacular
I agree. Oh, go ahead. Yeah.
I was going to say, like retinal detachments and other retinal diseases, submacular hemorrhages are another heterogeneous presentation. It's hard to know exactly what to do when. We kind of all have our our opinions, and we're guided a lot by the last patient that we saw that may have done well, or we heard something in a conference. But there is an attempt now that's to look at a randomized controlled trial of the treatment of submacular hemorrhages by, I think the lead investigator is Tim Jackson in England. And so it's a European effort to try to do a randomized controlled trial to see what are the characteristics that might be favorable for anti-VEGF alone versus clearance with TPA. So hopefully we'll know the answers to that more in the next few years. It's hard to study also because it's such an acute presentation, what to do with it, and then all the other systemic factors which may play a role, like blood pressure, smoking, presence of blood thinners, etc.
I think the case that Olivia presented was particularly good. You mentioned when you gave the presentation, the location of the hemorrhage, and the majority of that was superior in the picture that you showed. And I probably wouldn't have done anything but anti-VEGF on it. Obviously, you had an excellent result, but I think because the location and the size of the hemorrhage and the fovea and inferior to it were actually relatively clear, probably wouldn't have done the same. But so that's the variability that Dr. Smith was talking about. But great result, obviously.
Yeah. I think for me, a general kind of rule of thumb right now is that if it's small, thin hemorrhage, I think that anti-VEGF works great for submacular hemorrhages. I think if it's a medium-sized hemorrhage, it's recently been present and patients very motivated, I think pneumatic displacement is an option. For maybe a slightly larger hemorrhage and a pseudophakic patient, maybe vitrectomy would be an option. And I think for large hemorrhages that extend beyond arcades, I think in those, the risk of surgery versus potential benefit of outcome, is too great, and maybe just anti-VEGF also alone would be appropriate. But again, it's highly variable patient to patient.
I'm sorry, I missed the dose of TPA that you gave intravitreally. Typically, it's a higher dose. What is your range of doses that you use when you're considering subretinal delivery versus intravitreal injection of TPA?
So I injected 0.025 milligrams, and that's the only dose that I have experience with. Not sure if the panelists have any other that they've used. Maybe they can share.
That's what I used to. There are certain logistical constraints with getting office TPA, which does make it a challenging treatment modality. It is not an inexpensive drug and is often not covered by carriers. So, which is interesting in that you can get it covered in the OR setting, but not necessarily in outpatient clinic settings.
Okay. Well, we'll go on to our next topic, and we have another fabulous vitreoretinal fellow from the Retina Institute here. This is another first-year fellow, Dr. Prithvi Bandika, who's going to give us an update on the diagnosis and treatment of uveitis.
Okay, so thank you for that introduction. I'm just going to get started. I'm going to be talking broadly about some updates on uveitis, no financial disclosures. We'll start first with a case of a 35-year-old woman who's reporting new distortion and blurriness in the right eye that began a week ago, visions 2016 that eye and 2025 in the other eye. Notable exam findings, there is some vitritis in both eyes, and then you can see these Optos photos in both eyes showing kind of multifocal punched out chorioretinal lesions kind of scattered throughout. And then also on the OCT scan, there's kind of a lesion there with some intraretinal fluid overlying, which may be suspicious for like a choroidal neovascular membrane. Left eye also kind of shows a lesion there, but no fluid. So going to be mainly talking about some updates in white spot syndromes or white dot syndromes. So these are most prevalent in young, healthy, myopic individuals, and more commonly they're found in females. Primary white spot syndromes are thought to be autoimmune, and essentially it's due to some unveiling of retinal antigens and then combined with some genetic susceptibility and environmental stimuli, such as a viral infection, can be a trigger. And then recently, there are entities of secondary white spot syndromes, and these have been investigated in the context of other chorioretinal disorders. And I'll talk about this a little bit more in the presentation, but they're hypothesized to be due to damage to the choriocapillaris, the Brooks RPE complex, which unveil antigens and then kind of lead to the same cascade. So to briefly talk about one of the main entities in white spot syndromes, punctate inner choroidopathy, and then multifocal choroiditis. So the case we saw earlier is essentially a case on this spectrum of disease, and both of these entities are kind of on the spectrum. So they're both thought to be autoimmune. Usually they are bilateral. PIC, or punctate inner choroidopathy, typically has small, less than 250 micron punctate multifocal lesions. There's usually minimal anterior chamber and vitreous inflammation in this entity. Multifocal choroiditis usually has larger lesions with more punched out atrophic scar appearance, and usually there is some vitreous inflammation. Secondary CNV can occur in up to 83% of these lesions, so very important to monitor for this, especially if there are lesions within the macula. Treatment-wise, depends on the severity of kind of the presentation, but there are several different options. So you can definitely use systemic or oral steroids. Sometimes you may need something like mycophenolate or methotrexate, which are steroid-sparing agents, which I'll also talk about a little bit later. Intravitreal steroid implants are usable. You can use anti-VEGF therapy to treat the CNV, but this doesn't treat the inflammation if you feel like there's significant inflammation. And then severe cases may need kind of alternative medications such as biologics. So to go into some of the imaging features in these entities, so on OCT, you can kind of see this subretinal isoreflective material, and it's kind of splitting the RPE Brooks complex, and you can see hypertransmission kind of underlying through the choroid. And then active lesions actually have some focal choroidal thickening that you can sort of appreciate here compared to later in the treatment course. And then on OCT angiography, you can see some choroidal flow voids around the active lesion, and then secondary CNV, so which was kind of presented earlier by Dr. Blackerby. So this is a useful modality, especially if you're concerned of CNV. Fundus autofluorescence is a very useful tool in all white spot syndromes, and especially in something like PIC and MFC. You can see kind of this hyper autofluorescent ring that goes around the active lesions. And then the rest of the lesions typically are hypoautofluorescent. On FA, or fluorescein angiography, you can have active lesions showing early hyperfluorescence with late leakage and staining. And then ICG active or inactive lesions show hypocyanescence. So this is another case. It's a 29-year-old woman who's reporting a small central scotoma in the right eye that began a week ago. Vision's 20/25 in both eyes. There's no inflammation. Might be hard to tell, but there are kind of these subtle whitish yellow creamy lesions within the macula and also extending kind of a little bit beyond the arcades. And the autofluorescence makes this a lot more prominent. You can see these hyperfluorescent areas kind of throughout and even extending nasally. And then looking at the OCT cut through the macula, you can see most prominently, you can see that the ellipsoid zone kind of has these areas of irregularity, and the whole outer retina has some irregularity in these areas that you can appreciate. So this is multiple evanescent white dot syndrome, or MUDES, another white spot syndrome. It's an inflammatory disease affecting the outer retina, usually affects young middle-aged women. Typically, flu-like symptoms often precede the onset of this. Typically, they present with unilateral blurred vision, photopsias, scotomas with an enlarged blind spot, like our patient. And then findings, you usually see these whitish, yellowish, deep retinal lesions. You may have mild vitreous inflammation. In our case, we didn't. You can also have vascular sheathing and disc edema. The sizes of kind of these dots can vary. And the main thing to remember with MUDES is that the lesions are typically transient, and usually these patients kind of spontaneously recover without any additional treatment. Some of the imaging features to be aware of, on OCT, you can see kind of hyperreflective areas within the outer retina with possible disruption of the RP, and then also the ellipsoid zone or photoreceptor attenuation, which we saw in our patient. Choroidal filling is usually not affected, so OCTA and ICG are not too useful in this case. Fundus autofluorescence, depending on which type of autofluorescence you're using, you can either see hyper or hypoautofluorescence. On FA, you can have this wreath-like hyperfluorescence with minimal staining, leakage, and distaining. So unusual MUDES presentations include bilateral MUDES, which, while rare, does exist. Typically, the presentation of MUDES is in 20 to 50-year-old women, but can also affect younger patients. However, if you're seeing some presentation that may seem like MUDES after the age of 50, that is extremely rare. Has been reported, but again, extremely rare, so should consider other things in your differential. Recurrence of MUDES rarely occurs. However, if it does occur, it presents very similarly to the original presentation. Young patients or those who present with worse vision can have delayed recovery and may have persistent defects. So secondary white spot syndromes are something a little bit newer. So basically, these are similar presentation of the white dot syndromes that I talked about before, but kind of in the presence of a different trigger lesion. So a different retinal or choroidal lesion that leads to essentially the unveiling of certain antigens, and then you essentially get these autoimmune PIC MFC response or MUDES response. So secondary PIC or MFC, so it's pretty rare entity, but one of the retrospective case series I've seen, there was 16 patients. Essentially, the etiology for this were spread out, but inherited disease with pseudoxanthoma elasticum was the most common cause, and then there was also Best disease triggering this as well within this. None of these patients had prodromal symptoms, no recent viral infections, no vaccinations, and then none had vitreous AC or vitreous inflammation or vasculitis. The demographics were also very atypical compared to standard PIC or MFC. 1/4 of the cases were unusually young or unusually old. 13 of the patients were emmetropic or only slightly myopic, which generally in these white dot syndromes, as I had mentioned before, it's usually in myopic or nearsighted individuals. 10 cases were unilateral, whereas this typically presents bilaterally, and then there were no obvious environmental stimuli. So how these patients were treated, 7 were treated with oral steroids, and then 7 had received anti-VEGF for concomitant CNV. Secondary MUDES, also named epimudes or MUDES-like reaction. This may not present simultaneously with some other triggering retinal or choroidal disease. Tends to be actually in older patients, which contrary to regular MUDES, which is kind of the 20 to 50-year-old range, typically has smaller spots on imaging, typically does present kind of around a trigger lesion. Sorry, I don't know why it's moving forward. But it does clinically follow a similar course to primary MUDES, and there's many different causes of lesions that can lead to this. Treatment of non-infectious uveitis is another very important topic I just want to touch upon. So there's kind of 2 main things that you can use, steroids, and there's local or ocular therapy. You can use drops, intravitreal injection, intravitreal implant, such as a dexamethasone implant. However, all of these can lead to IOP issues, so that's a main concern with this. Systemically, you can use oral steroids, but this can lead to significant systemic side effects, especially if it's used long-term, like osteoporosis, hyperglycemia, insomnia, and GI issues. Other steroid-sparing agents you can use are antimetabolites such as methotrexate or mycophenolate, which I'll talk about in another paper shortly, or T-cell inhibitors. And then lastly, if none of these are working or getting adequate control, you can use biologics such as adalimumab, which is Humira. Going back to our case, the same case I had presented in the beginning of the presentation. I think one of the best ways to treat this, especially with the CNV in the right eye, is to likely start this patient, especially because they have bilateral disease, on oral steroids, typically at 1 milligram per kilogram per day, and then also treat concomitantly with anti-VEGF for the CNV in the right eye. So briefly want to talk about this paper, which looked into the main kind of first-line non-steroid agents, so mycophenolate and methotrexate. This was kind of a worldwide randomized control trial, and essentially the main things it looked at were treatment success at 6 months, and essentially this required control of inflammation in both eyes with a few additional restrictions. The interesting things here, if you look at the methotrexate group, you can see that treatment success overall in all non-infectious uveitis was higher than mycophenolate at 66%. But if you break it down, interestingly, methotrexate does better in posterior or pan-uveitis at 74% versus 63% versus 55% in mycophenolate. But this is reversed in anterior or intermediate uveitis, where mycophenolate performs better. Oops, sorry. There was kind of this sub-analysis of the same trial looking at what features of the uveitis led to failure of both. And essentially retinal vasculitis was the only finding with a significant odds ratio. So when you do see retinal vasculitis in a uveitis patient, you should be concerned that you may need to escalate to other more potent steroid-sparing agents such as adalimumab or other agents. Another trial that was just recently published is the MERIT trial, which was looking at intravitreal therapy for uveitic macular edema. And this was also a randomized control trial looking at intravitreal ranibizumab versus intravitreal methotrexate versus dexamethasone implant. And they were all randomized 1:1:1. And the primary outcome is reduction in CST at 12 weeks as assessed as a proportion of the baseline kind of central subfield thickness. Looking at this, the main takeaways were that the dexamethasone implant group was significantly better than methotrexate and ranibizumab at all time points, so weeks 4, 8, and 12 in terms of CST improvement. Additionally, the secondary outcome showed that there was significant improvement in the BCVA for the dexamethasone group, but not in the ranibizumab or methotrexate group. Oops, sorry. And then the incidence of IOP elevation, however, is something to note, which was higher in the dexamethasone group, which is expected given it is a steroid. Yeah, thank you.
Dr. Bomdika, thank you so much. That is a difficult topic to tackle within 15 minutes, but you did a nice job of it. I was going to ask the panel, like, how do you guys approach a uveitis patient? Do you start with systemic therapies, or do you go straight to like a localized delivery of a steroid, combination thereof? What's your approach?
Typically, I go systemic, Brad, once I've gotten an initial set of labs. I find that you have to hit these pretty hard, pretty fast. And PO steroids works really well for that regard and is well tolerated.
Yeah. I tend to do the same thing. I think the workup obviously is important to make sure it's not an infectious cause, but the systemic treatment with oral steroids is something you can turn on, turn off fast if something comes back or something's not working right.
Exactly.
And often these patients are younger. I don't want to induce the cataract if I can avoid it too.
Yeah, absolutely. Dr. Siddiqui, do you have any pearls of wisdom for approaching these patients and using uveitis through your course of fellowship training here?
Yeah, I like to approach a systematic way. Getting a good history is typically key as well. I tend to, with patients with a first bout of like anterior uveitis per se, I don't generally get a bunch of lab workup. But if they have, chronic uveitis or unremitting, and even with anterior uveitis, if it's not getting better over 2-3 months, then I think lab workup is warranted. And then, imaging is typically key. I think imaging can help us pick up a lot of things. OCT is very helpful. It can pick up little vitreous opacities that can clue you in as well about inflammatory reasons.
Yeah, absolutely. I agree totally.
Do any of you treat with any steroid-sparing agents by yourself without a rheumatologist? Or if you're escalating past steroid treatment, do you often refer for rheumatology eval as well?
I tend to do it in conjunction with rheumatology. I know we have some of our providers at TRI will prescribe non-steroidal treatments, steroid-sparing treatments, but for me personally, I just am more comfortable having a rheumatologist help me navigate all the systemic stuff so I can focus on the retina.
It's important to get rheumatology on board early because depending on where the patient lives, it may take some time to get them in to see them. So even though we can manage it well, if it looks like it's heading that direction, that earlier referral is better.
Also,
Agreed.
Many times the primary care physician will feel comfortable managing these drugs, and it's mainly just looking for toxicity, whether it's kidney toxicity or liver toxicity with the various agents.
Also, from a practical standpoint, if you're going to use biologics, it's becoming more and more common. Insurance companies will want a rheumatologist on board before they approve an expensive biologic treatment. They will not rely on an ophthalmologist assessment.
I think another key thing to bring up, it was a great kind of discussion on the differentiation between MFC and PIC, but especially in the St. Louis area, POSE is a common diagnosis and another diagnosis that we can often mistake for MFC or PIC or vice versa. So sometimes writing off a patient as POSE is a disservice to them, especially if they require long-term immunosuppression.
Yeah, absolutely. Thank you, Dr. Patel. Okay, with that, we'll go on to the final session. We just got a couple of medical cases that we want to highlight here. Pull up my screen. So this is a patient, a 69-year-old white female with 1 week of blurred vision. And her history is notable for nephrolithiasis. She also had a recent yeast infection, and she stopped her antifungal treatment about 1 week ago. And so here she is. Her left eye's okay, but here's her right eye with this central white opacity right over the fovea, maybe a second white opacity near the infratemporal arcade, perhaps a cotton wool spot, a little difficult to tell. And then you can see this OCT cut through the central fovea showing this hyper reflective material within the retina. basically spanning the entire depth of the retina with some hyperreflective foci surrounding it. So what do you guys think? What do you think the differential diagnosis is here, and how would you approach this patient?
I think given her recent history, you definitely need to make sure that it's not, a systemic spread of any infectious agents that are here. It's just too close to call for that. You can do, I kind of harken back to my lecture, you can do an OCTA to kind of look at some inflammatory angiogenic changes. But this is clearly one where a detailed history and some lab work may be appropriate for.
I think another thing is if you just look at this, it kind of looks like a cotton wool spot in the fovea too, but like you alluded to, Dr. Smith, it's in every layer of the retina, not just localized to one. So something is off about this.
Yeah. Well, let's say her history, significant for the nephrolithiasis, this kidney urological procedure, and actually then having serology that demonstrated a past yeast infection. So we decided to treat this as a fungal endophthalmitis. Options include, doing a vitrectomy with intravitreal antifungals or starting systemic antifungals, whether it be oral or intravenous. In this situation, we actually elected to just do oral antifungal treatments. And so this is what her progress was over a course of about 12 to 14 weeks. So you can see that lesion is kind of melting away until she finally got to 2060. And that's about as good as it could get. And she had a little photoreceptor disruption, which I think limited her final outcome. But the fungal ball cleared up nicely just with the oral. I wonder what you guys think about this. Is this a typical response, or should we have done intravitreal injections?
I think you did the right thing. When I was a fellow in Boston, now many years ago, there was an epidemic of this in the IV drug use community. It was actually coming from the little lemon squeeze bottles that you get at the grocery store of lemon juice that had contaminations with fungus that were used in some process of the drug administration process. So I ended up seeing about 8 of these in 1 month. And they responded incredibly well to oral voriconazole because oral voriconazole's bioavailability is essentially equivalent to IV. And then studies have also shown that intravitreal versus oral doesn't actually make that much difference. You need to get it not just in the vitreous cavity, but where did this fungus come from? It came from hematologic dissemination, right? It was fungus that was flying through the blood vessels and then eventually got into the retina. So it intuitively makes sense that if you want to attack where it came in from, you got to go through the vasculature instead of the vitreous. So I think this was a great thing. As long as you have an etiology for why this person would be fungemic, I think outpatient is great. If I see some young, healthy, otherwise healthy person with fungus in their eye, I'm admitting them for workup until I can really know where it came from.
What would your workup have been without the history of the recent yeast infection?
I mean, I don't actually control the workup. I just consult with our ID colleagues. We're looking for fungal endocarditis. We're looking for where the source of fungemia could be. And so urinary tract system's a big one. But if they're otherwise healthy, my suspicion is that they often are not admitting to IV drug use because that can be a very common thing if they have no other risk factors. And if that's the case, fungal endocarditis is a significant source of morbidity and mortality in these patients. That's what I want ruled out.
Yeah. Unfortunately, she did okay. I kind of what you were getting at about this lesion still has access sort of to a blood supply, whereas if it was isolated in the vitreous, I'm not sure it would have responded this way. It probably would have kept on forever until we gave intravitreal voriconazole. But because voriconazole is so bioavailable, I think it worked. I think voriconazole, for the quiz takers, you can give it just about any way and it gets to the eye, except if it's a cream. I'm not sure about that. So, but any other method might work. Dr. Blackerby and I had a case of a fungal ball a few years ago that we participated on. Is another patient who had to use a catheter, self-catheterization, because of a diagnosis of multiple sclerosis. So I just wanted to show you how tenacious these fungal balls can be when they're in the retina. So this is actually Dr. Blackerby's handiwork here, and a fungal ball coming through the retina, off in the periphery. It just doesn't flake off. It's, as you saw in that OCT, it's kind of incorporated full thickness through the retina. So I'm trying to show it to him with depression, and he's meticulously getting that thing off there in the most atraumatic possible way. And eventually it comes off. This was a fun and exciting case. We tried to get creative with removing this in total so we could send it off to histology. So I had the bright idea of putting a 18 gauge catheter in the sclerotomy so we didn't damage it. And as soon as we took the instruments out, I think the thing shot out of the wound and landed on the drape somewhere, but we got lucky and found it and then passed it off to histology. One of the interesting things about this case is that the microbiology was negative, but the pathologist at St. Luke's actually found the hyphae on a histological slide. So that's how we made the definitive diagnosis here. So we'll go on to the next case. This is a patient who, 54-year-old white female with a history of blur for a month. She had some floaters, and there was some vitreous cell noted. Anybody want to take the diagnosis here?
You got a macular hole there, Brad.
I'm glad you agree. I thought so too. She did have some uveitis as well, so I thought Dr. Durrani, who unfortunately couldn't be with us today, has talked before about giving intravitreal Kenalog for macular holes with these cystic spaces. So with her voice in my head and seeing this patient and having two reasons for Kenalog, we did give a Kenalog. And I'm just going to move through this quickly since we're just about at time. But she did have a peripheral lesion noted here, which was hyperechoic on ultrasound and kind of lit up with fluorescein angiography. So sometimes you'll see these lesions in the setting of uveitis. But we gave her a steroid injection, triamcinolone intravitreally, and the hole closed. Cystoid spaces went away and the hole closed, and it helped her uveitis as well. She did okay. I gave her a subsequent injection, but it seemed not to work as well. And then over time, she developed this little lamellar hole associated epiretinal proliferation there noted by the arrow. So I was afraid this was just going to keep it open. So it ultimately took her to surgery and did a little flap of internal limiting membrane and covered the hole. I didn't do anything to the tumor in the periphery of the retina, so you may be wondering what that is. Well, it's a vasoproliferative tumor that can happen in the setting of intermediate uveitis in some cases. So that's how we treated that. Any comments?
Do you think that the vasoproliferative tumor has contributed to macular hole formation?
I think it's possible. I think maybe with the inflammation associated that caused the vasoproliferative tumor, or as a secondary response, maybe the cystoid macular edema opened up in some way with concomitant vitreoretinal traction from some inflammation in the peripheral retina from the vasoproliferative tumor. I think it may have been associated with it in that way. But sometimes we do have to freeze these or laser these, but this one didn't require direct treatment.
Mm-hmm. It's amazing the outcome with LHEP. I know those can be very challenging to remove and close.
Yeah, it's interesting, just in a standard lamellar hole, 10, 15, 20 years ago, I remember thinking, wow, I just don't get as much of a good outcome as you do with just a full thickness macular hole. Mm-hmm. And then we kind of started hearing about this LHEP with the advent of spectral domain OCT. We could see this pathology much better on OCT. And then it became clear that, well, maybe we shouldn't remove all this material. In fact, leave some of that material behind the hole in lamellar holes. And they seem to do better that way. How do you guys approach those? Must be lunchtime.
Yeah, I was gonna say, I think the silence is everyone just does what you do, Brad.
Well, I learned from you guys. It's a collaborative effort for sure, and I really want to appreciate say thank you to again all of you guys here, my colleagues here at TRI, for devoting your time to doing this. Just so you attendees know, this program, this is the 11th year we've been doing this, and we've had tremendous support from the Retina Research and Development Foundation in financial backing for this, but the time that's devoted to putting these talks together and submitting them with Nancy's help for accreditation, it's all a labor of love. No one's getting an honorarium or getting paid for their time here. It's all devotion because we love taking care of your patients. We love the craft of taking care of retinal diseases. And I hope you know that we appreciate your trust that you give us in taking care of your patients. And we hope that we'll see you next year at the 12th Spring Retina Update. Don't forget about the quiz. Make sure you turn that in. Make sure you fill out your evaluation forms and turn those into Nancy via email by May 5th so that you can claim your credit. And stay dry out there. I think it's 49 degrees with a 100% chance of rain, so be careful out there. Stay warm, and we will see you next April 2026. Thank you, guys.